Um, Good morning, everyone. It's such a pleasure to see you all face to face in one room. It doesn't happen often, and I know that you're all incredibly busy people. So thank you so much for being here. My name is Marley. For those who don't know me, Marley Quinn. I'm the head of the Rehabilitation and Disability Unit here at WHO Ukraine Country Office, and also together with Ksenia and Pavlo, and now the lovely Natalia, we are leading the Rehabilitation Working Group here, and I'm going to hand over to Natalia to say a few words in just a moment. Of course, we're so grateful that you're here. We know that the ongoing Russian aggression against Ukraine is fatiguing. It creates emergencies within emergencies, and it is quite a big job to continue to respond and to meet the needs of Ukrainians. The needs are increasing for physical rehabilitation, and also addressing psychological injury and integrating back into the community and addressing social care needs. And so this is really the direction of WHO, and I hope that today we can also have some discussion around how we can work in a more integrated way to develop integrated rehabilitation service models that address not just the physical needs, but the psychosocial care needs as well. So thank you so much for being here. Very brief on my side. I want to introduce Natalia Melenchenko, who is probably not new to many of you. Natalia from Momentum Wheels for Humanity and Deputy Director of the Rehabilitation for You Forum. We're very grateful that you have decided to co-chair this group with us. So thanks for being here, and over to you.
Yeah, thank you, colleagues. It's great to see you all. I would like to express my high priority to join as a co-chair together with WHO. Momentum Wheels for Humanity working in the different areas, in humanitarian areas, and of course are the main implementer of Rehab for You project in Ukraine. So we are super pleased to be here and to bring our knowledge, our work, and what we are doing in terms of our activities in Ukraine. So thank you to all of you that you join in person this meeting.
Great, thanks, Natalia. And before we get started, I think, yes, Sinya.
I have some couple of technical issues to discuss with you.
Please.
First, I would like to check if we can hear colleagues online. Please, somebody, can you raise a voice and let us know that we can hear you?
Yes, everything is okay.
Thank you. Just to make sure that we are not speaking on mute and people can hear us online. And also, to be honest, I was not sure how many people we're going to get here today, but luckily we have all the seats. However, people are still joining, so they will scoop inside. But for the first day, we were expecting like 15 people, but now we have 30. So I'm grateful that you're all here. But about interpretation, we have simultaneous interpretation online, and I've texted an email that please, Ukrainian speaking participants, can you please take your headphones? However, today we will have a couple of presentations in Ukrainian language from here. So we will check how it will be more comfortable, because I can see that probably the biggest group of people is Ukrainian speakers or speaking in both languages. So maybe I will ask English-speaking colleagues to get headphones and use simultaneous interpretation. But we will figure it out. Thank you so much.
Great, thanks, Sinya. Sinya, when you have a moment, could you let me into the meeting so I can share my screen? But while we're doing that, colleagues, I know many of us are familiar with one another, but sometimes it's more difficult to recognize one another when we're usually sitting behind a screen in a tiny box. So why don't we take a moment just to do a round of introductions so we all feel familiar. Hello, starting with you.
Hello, everyone. So I'm Alice. I'm the rehab specialist working for humanity and inclusion.
Hello, good morning. I'm Sam. I work with the health cluster based in Dnipro, and I'm the focal point from the cluster to the rehab working group. Good to see you.
Hello, I'm Marina Alexandrova. I work for Rehab for You project and responsible for rehabilitation services on Hromada level, beach level.
Barushov Tatiana, physical therapist, the head of the board, Ukrainian Physical Therapy Association.
Good morning, everyone. Alexandra Ferlikovska, Protection Cluster Coordination Officer.
Igor Ignatiev, International Committee of Red Cross Physical Rehabilitation Program, Deputy Program Manager.
Hello everyone, Svetlana Goroptsova, International Organization for Migration, Emergency and Recovery Health Program Officer.
Good morning, my name is Євгена Прилипка. I'm the head of the Expert Association Healthcare Transformation Pro.
Hello, my name is Ksenia Deva and I'm Associate Rehabilitation Officer and part of Rehabilitation Working Group. Thank you.
Hello, my name is Lisa Nepipiro, Здоров'я Health Expert.
Hello, my name is Natalia Tulinova, CEO Здоров'я.
Good morning, my name is Taras Gain. I'm a representative of Louis State Region Administration, Chief of Staff.
Hello, my name is Yehor Varespa. I'm President Charity Foundation Medical Mission.
Hi everybody, my name is Anna. I'm from British Red Cross. Hi colleagues from ICRC, and I'm a program manager for Burns Unit in Kyiv.
Hello everyone, my name is Denis Nagorny. I'm member of board of Ukrainian Association of Physical Therapy.
Good morning, my name is Paula Pavlenka and I work with Anabel Ukraine, with Belgium Agency for International Cooperation.
Colleagues, my name is Yana Martishina. I'm from Enable 2. I'm health expert working with the health sub-department and working with Rehab.
Hello everyone, I'm Maria Marelli. I'm the pediatric rehabilitation expert for UNICEF.
Good morning, my name is Lina Yonenita. I'm from Lithuanian Central Project Management Agency and I'm responsible for Lithuanian rehabilitation program in Ukraine.
Vladislav, over to you.
My name is Vlad Andrinsky. I'm Senior Advisor, Project Rehab for You.
So I already introduced myself. I'm Natalia Melnichenko. I'm a country director for Momentum for Humanity and Deputy Chief of Party for Rehab for You project.
And I think everyone knows me now. Marley from WHO. So why don't we hand over to colleagues online.
More difficult to have a round table better.
Colleagues online, you can raise your hand just to have an order and step in one by one. Yes, Kasia, please.
Good morning, colleagues. Good to see you. I am Kasia, Protection Cluster Coordinator, and I work with Sasha Ferlikovska, who is with you in the room. Back to you.
Thank you. Lesia, we see your hand also, please.
Good morning, everyone. My name is Lesia Kolendyak. I am Physical Rehabilitation Technical Director for Rehab for You project, working with Natalia and colleagues.
Thank you. Katerina, please.
Good morning, everyone. My name is Katerina. I'm Explosive Ordnance Victim Assistance Officer, Danish Refugee Council.
Thank you. Evelyn.
Good morning, everyone. I'm Evelina Huizinga. I'm the rehabilitation expert.
Is it power connection or it's not? Evelyn, I'm sorry, but internet is interrupting. Okay, Evelyn, can you hear us? And you're back on the screen. I think we will give it some time. Maria?
Hi, everyone. My name is Maria Ramiro. I'm supporting the rehabilitation workforce evaluation in Ukraine. I'm happy to be here with you.
Yeah, I'm trying to get a normal view, but I think we will switch to gallery. Thank you, Maria. Андрій?
Добрий день, мене звати Андрій Гавриленко, рехаб-офіцер, компанія FHA 360.
Thank you. Nikita, please step in.
Morning, colleagues. My name is Nikita Bernikov. I am IT consultant and representative Rehab for your project.
Thank you. Evelyn, I'm sorry, but now we can see you, and I hope we will be able to hear you properly. May I ask you to reintroduce you?
Yes, thank you. I'm Evelyn Huizinga. I'm the rehabilitation expert with Solitaire. I hope you can hear me now.
Yes, yes, it was perfect.
Okay,
Thank you.
Thank you.
Anna, would you like to introduce yourself?
Доброго дня, мене звати Анна, я представник організації RWG International, Deputy Health Coordinator. Hello everyone, my name is Anna, I am representative from RWG International, I'm a Deputy Health Coordinator.
Thank you, Anna. Do we have somebody else online who would like to raise a hand and introduce themselves? Serhi, please.
Good day, dear colleagues. My name is Serhi Kolisnik. I'm board member of Ukrainian Society for Rehabilitation.
Thank you. Other colleagues would like to introduce themselves? Because we are not pushing people online. Offline, everybody introduce themselves. Okay. I think we can wrap up the round of introduction if nobody else would like to step in.
Great, okay. I just want to check that everyone's had a chance to have a look at the agenda for today. Or shall I just talk us through quickly what we'll be up to? Okay, so firstly, colleagues, I'm just going to talk you through some of the results of the strategic session, which was a session led by the Ministry of Health with the support of WHO in May over 2 days. It was a closed session. It was a very small group in order to take stock of how we as a sector are progressing on the critical priorities that the Ministry of Health set with regards to rehabilitation systems development. So I'm just going to share with you some updates on that, and we can, of course, discuss. I'm then going to hand over to our health cluster colleagues, Sam, to give us some updates on what's happening in the broader health cluster setting, and talking, of course, about reporting, geographical coverage, etc. So thanks, Sam, for being here. Then we're going to hand over to Ksenia and our dear colleague, Maria Ramiro, who is online, to share with us the most recent updates with regards to the workforce assessment of the rehabilitation sector in the country, which we're very much looking forward to hearing about. And we anticipate, hopefully, that the process will be complete in a few months' time. Then we're going to hand over to Yevgen, who is going to be sharing with us key updates on Yevgen's project and the work of the organization. And before we go to lunch, we'll hand over to Vladislav from the Rehab for You to share some really important and interesting findings on the assessment that was conducted this year on primary healthcare settings at the grammata level, of course. We will go to lunch at 12:45 and we'll try and stick to that and not keep you hungry for too long. And then when we rejoin, this is in the afternoon, we really just want to have an open space to take stock, to evaluate where are we? Are the priorities, in your opinion, still relevant? This is an incredibly dynamic environment, and we need to always be asking ourselves the same questions over and over to make sure that we're driving in the same direction, and to really hear from you as a representative of your organization, but also as a part of this collective, you know, where the key gaps remain, where the key priorities are, particularly in the humanitarian space, and what we could do, or what, if anything, what we need to do to communicate to the broader health architecture, to donors, etc., you know, what we really see as key priorities, where we need resources, where there are funding gaps. We know, of course, this year has been incredibly difficult for the rehabilitation sector in Ukraine, and also the broader health and protection, other sectors as well, given the volatile international political situation at this moment. So it's really a key time for us to hear from you. You know, we know organizations have lost funding. We know organizations have had to scale down. They've had to reprioritize and sacrifice some of their programming in order to keep operating. And we really want to hear from you about that, because as WHO, it's really part of our role is to be a support and to also provide you a platform to elevate the needs, the priorities, and your perspectives, and to be able to communicate that to the broader community. And that's what we're here to do. So we're really looking forward to having a deep dive discussion, informally, safe space to share, and then we can come together and agree on, you know, what actions we can take going forward as a group to support one another and communicate our needs. And then we have some more coffee and some more snacks because it's Friday. So I hope you will enjoy that aspect too. Great. Okay, so let's get started. I'm just going to share my screen, colleagues.
Are you inside the meeting, Marley?
I am now, but maybe you need to assign me.
Yes, maybe.
Please. Thank you, my dear. It's normally here. We give it a minute.
Paradox option. It's allow, which you can allow. Here should be somewhere.
Usually, thank you. Yeah. Thank you. Oops, the daisies. Okay. Oh, yeah, here we go. Great. And colleagues, just before I get started, I just wanted to make a comment on the coordination structure around rehabilitation at this moment in time. As I'm sure most of you are aware, the Q4 of last year, the Minister of Health requested a broader rehabilitation coordination mechanism under his leadership with the support of WHO and Rehabilitation for You. So together we worked to set up the coordination forum. Of course, it's between Q4 last year and Q1 this year. It was an incredibly difficult and let's say interesting, for lack of a better word, time. But the forum is up and running. And I just want to say that there is not necessarily a duplication. We know that with the National Rehab in Healthcare Forum, it's led by the Ministry of Health and it sits under the Health Sector Working Group. And that Health Sector Working Group is led by Victor Lashko, the Minister, and the WHO representative. And so we are one technical group underneath that structure. Stay with me because you have to start imagining all of these structures. And then what we developed is called the Rehabilitation Technical Support Unit. This is a small team that sits here at the WHO office and supports directly the Ministry of Health in policy, legislation, regulations, and coordination. So the lead of the rehab support unit, her name is Maria Krivakon. Unfortunately, she's not here today because she is traveling. But myself, Maria, and the rest of the team work together to make sure that we're able to provide support to the Ministry of Health in terms of HR and other resources to progress the agenda, mostly to do with regulation, standardization, some of that really health system strengthening work. Under that rehab support unit is where the working groups need to fit in and report up into the rehab support unit. And then we're accountable to the Minister and our representative, Jano, on the progress of those working groups. And I'm happy to have Maria come along again to another meeting and answer any questions there. But I think the distinctive difference is with these two working groups is, of course, this working group sits under the health cluster. So in essence, it's really about emergency response, typically. And we know in Ukraine that this is almost impossible to pull apart. And so often partners who are attending this meeting might be working in Eastern Oblast, for example, and working within a sort of shorter term response model. But just to say, please, if you can, join both coordination mechanisms. This group is very much on the emergency, with the emergency focus. Many partners are working with the Ukraine Humanitarian Fund, etc. The forum is broader stroking and looks more at the 6 building blocks of system strengthening. So not just service delivery, but policy, governance, workforce, health financing work, etc. So it's much broader. So I hope that that is clear. We will start to develop some updates from the forum in terms of health service coverage and gaps, etc. So we are working on those sort of snapshots to inform you of who is doing what and where, focusing on the national health system. The reporting that we ask partners to do in this space is really looking at the non-government actors that are responding to the needs. And then our job is to pull all of that data together to present you with a more descriptive picture. But we certainly don't want you to spend half your time reporting. So we're trying to really streamline as much as possible. So we thank you in advance for your patience there. And if you have any questions on the forum or on the coordination architecture with regards to rehab in Ukraine, please raise it with myself or Natalia. And we will ask Maria to come along. She's in South Korea at the moment, but we will ask her to come along when she's next available. And finally, with the Rehab Forum, we have online bi-monthly meetings. So the next meeting is online on the 2nd of July, and that will be led between WHO and, of course, ultimately the Ministry of Health. So please join us there. and reach out to me directly if you are not already on the mailing list and would like to be. Okay, great. Okay, so let's get stuck in. What's the time? Good. Okay. So as I mentioned, colleagues, in May, we gathered a small group of rehabilitation experts in the country to revise the key priorities that were set for 2025 by the Ministry of Health, and to discuss and evaluate ourselves and the sector against those priorities. So the 10 work streams that have been prioritised for this year by the Ministry of Health include the Centres of Excellence Initiative, development of children's rehabilitation, development of community-delivered rehabilitation, capable network finalising, so that's the non-specialised rehabilitation units in the country, improving the rehab pathways, which I think is particularly critical, adopting rehabilitation care standards, and I know we have colleagues in the room working on that directly. Human capital development, we will hear a little bit about the assessment later. Provision of acute rehabilitation care. When we talk about pathways, I think the acute element and of course the community element are the obvious missing pieces at the moment at a national level. Rehab financing and functional assessment tools, because we know that this is really important in terms of how we better understand what is happening or what kind of rehabilitation is being provided within a rehabilitation unit. And one of the critical ways in order to do that is to introduce functional outcome measures into teams, but we know that teams are using them, but rather that they are entered into e-health, so we can better understand the quality of rehabilitation and measure what difference it's making for patients who are receiving rehab in the country. Okay, so in terms of the Centres of Excellence, I've just included here the key takeaways that were recorded, the recent progress, and the key partners who are involved. And I think the Centres of Excellence are probably have the most partner coordination or partner contribution across the board. And I will definitely share these slides with you, colleagues, after the session. So we know in 25 at least another 41 facilities will be covered. 60% of the existing non-children capable network will be covered by the end of Q1 in 2026. There's a need to agree on the strategic vision of the COEs for the midterm perspective. So where the COEs are moving, they're developing, where do we go next? How do we consolidate this approach? How do we anchor this within the education system, etc., and ensure continuity in the longer term? We have new training activities that will be launched in Kleven and Ochma this year. And we know that some of our rehab teams are requesting additional training, which tends to be more specialized diagnosis specific. Okay, I'm going to just move quickly and then we can discuss. So in terms of pediatric rehabilitation, patients of Ukraine who I don't see here, I think maybe weren't able to make it today, have prepared a concept note for the Ministry of Health, which determines several critical priority activity areas and which can be implemented under the leadership of the new Pediatric Rehabilitation Working Group. So this is a working group that is being assembled under the National Rehabilitation Forum and is led by Maria Morelli here from UNICEF on my right, and also Anastasia Boychuk from Patients of Ukraine. I don't know, Maria, if you want to speak to any of the points, or I don't want to put you on the spot.
Yeah. No, it's just that, so it's programmed to have a first meeting to clarify with the Ministry of Health the priority for the pediatric working group specifically next week. And then we will have, we will receive an email about who is working on pediatric rehabilitation will be invited to then participate to the working group. It's the same idea, is to see who is there, see who is doing what, and how we can contribute to the priorities of the ministry and of the nation as a general objective.
Great, thanks, Maria. And so you can see there, colleagues, some of the key areas noted by the group were, of course, strengthening the capacity of children's hospitals within the capable network, identifying core professional competency lists and training, equipment, etc. Adopting clinical care standards, which of course is really important for pediatric rehabilitation and also across the rehabilitation board as a whole. The introduction of functional assessment tools for children and adopting the list of conditions for inpatient children's rehab. So if you have any questions or comments, or you would like to be part of the Pediatric Rehab Working Group, please reach out to myself because you have my email, but probably more efficiently, you can also reach out directly to Maria to be added to that mailing list. Great, so community delivered rehabilitation. And I know that a lot of colleagues here, a lot of organizations are working on this already and have been working on elements of this over the previous years. I think now it's clearly a critical priority for the country, not just because we know that often patients, or more often than not, patients will leave the inpatient rehabilitation setting, wherever that is, and go home and decline quite significantly physically, but also in terms of their mental health for some of the patients with more severe injuries and who are still moving through the adjustment to illness and disability process. So we also know that in Ukraine that there are many inpatient rehab facilities that have quite long waiting lists. We also know from the NHSU data that many people who are receiving rehabilitation care in the country would be better served at home, particularly older people who are at a higher risk of infection while in an inpatient hospital facility, etc. So community delivered rehab is important because patients require a continuity of care after the inpatient setting, but it's also a strategic priority to unblock beds, to reduce waiting lists, and to rationalize patients across the pathway, ensuring that the most severe patients who are most critical are not waiting on a waiting list, and that we keep patients who are at risk of infection or deterioration for other reasons are safely seen at home with their families. As you might be aware, WHO is working now on piloting community delivered rehabilitation in Vinnytsia. We will start that process in Vinnytsia on Tuesday, initially working with local authorities and bringing them on board. And then we will create master trainers for a specific set of rehabilitation interventions with regards to mobility, self-care, and communication. And we will pilot this model anchored most likely in general hospitals which have outpatient rehab facilities. So it will be funded through the NHSU, through the outpatient package, but those rehab workers will be mobile and able to reach people in their home and coordinating with primary healthcare physicians and nurses. So we're looking forward to being able to share something with you in the coming months on the progress there. We know also that patients of Ukraine have a lot of wonderful experience in community delivered rehabilitation, and they're working on a broader concept note for the strategy development for the country. We know Humanity and Inclusion also have wonderful experience in community delivered rehabilitation. and also Momentum, Wheels for Humanity, certainly GAR, Group for Active Rehab, and many others. So as we move forward, as at least as WHO, we're wanting to learn from other partners, not duplicate, and make sure that we can work in a way that benefits and generates lessons for the broader collective. Okay, so finalizing the capable rehab facility network. So we know at the moment 187 out of 230 cluster and supercluster healthcare facilities in the network are contracted by the NHSU, okay, 81%. And the Ministry of Health is really aiming to fully complete the facility network by the end of 2026. So the progress has been quite rapid, particularly given the situation at this moment in time. One of the critical areas of the facility network I've already mentioned, we'll speak in more detail to the focus on quality of rehabilitation care. We know that the way that it's monitored at the moment is the best that has been possible, but we're really focused on trying to measure quality outcomes for patients and also begin to address the full pathway, making sure that over time, patients who are sitting in acute beds outside of the stroke package can access rehabilitation care. At the moment, WHO and Médecins Sans Frontières, MSF Belgium, are working on developing an acute rehab care pilot. We're hoping to go ahead with in Zaporizhia and Dnipro later this year to generate lessons, to look at task sharing, to look at rationalization of roles and responsibilities across rehab and non-rehab teams, to see how we can at least deliver the minimum standards of acute rehabilitation care in that very early phase. But of course, it's a complicated process. We know that the health financing for rehabilitation does not promote necessarily or reward facilities for acute rehabilitation care. And so it's very much a multi-stage approach, but we look forward to keeping you updated on that. Adoption of rehab guidelines, standards and protocols. I know some of you in the room are probably working or are part of the working groups who are developing these. We have 6 working groups that of course are led by the Ministry of Health. They're developing standards for spinal cord injury, amputation, fractures, stroke, and acute conditions in premature infants and children with cerebral palsy. The colleagues are also working on protocol development for these conditions and selecting new conditions for future standardization. So again, what are the critical priorities? And we will talk about that, but what kind of patients are you seeing? Are your implementing partners seeing? This is really critical information for us to inform the broader system strengthening work. The colleagues during the session flagged that there is a need to provide additional methodological, operational, and legal support to the standards process, focusing on supporting those working groups. And also a request for training on evidence-based resource use for the working groups. And it had been provided by Solitaire Foundation in the past, and there was a request for further support with that in that regard. And Patients of Ukraine is leading the legal support there. Human capital development or higher education. I'm just going to read out a few, some of the key points. So higher education standards for rehab. Specialities, of course, have been adopted. Master's programs in prosthetics, orthotics, and speech and language were launched in 2024. And there's a need to contribute to the enhancement of quality of education programs, in particular by amending the higher education institutions accreditation process, supporting these lecturers' professional development, as well as enhancing the unified state qualification exam. So that was quite a meaty topic during the session. And I will hand over later in our workforce session to go into more detail there. Acute trauma, I think I've already touched on this a little bit. I made mention of MSF Belgium. Please do come to the bi-monthly forum update on the 2nd, because MSF will give us a detailed presentation on the work that they've done so far and the planning going forward. Adoption of equipment lists and supply, and relevant equipment is required for acute rehab providers. And of course, defining personnel roles for acute stage rehab, which is something that I mentioned earlier. We know that most unfortunately, the number of traumatic injuries in the country is unprecedented, and that unfortunately, there is no sign of them slowing until this awful aggression against Ukraine comes to an end. So the thinking really is, how do we continue to develop the rehabilitation system in a quality way? We know the president of Ukraine pointed out that rehabilitation is a critical priority for him and the president's office, and also has an ambition to develop the strongest rehabilitation network in Europe. So, and I think this is a wonderful ambition, and we're all on board with this. But at the same time, when we have a shortage of rehabilitation professionals in the country, we also have to take an approach of good for everyone, but instead of excellent for few. And this is really a principle that comes from, responding to epidemics. Okay, this is how you would structure it. And I know I'm probably preaching to the choir here. But what we're looking at is, how do we look at the role of rehabilitation assistants, rehabilitation professionals, nursing in acute care, and can we come up with a service model that supports triage, but also rationalization of roles and time and skills across that space without sacrificing quality care in the subacute rehabilitation phase. So it's quite complex, and we are ambitious because we believe that this could be, really quite impactful for the country. So we will keep you updated there. But a big thanks to MSF Belgium, and unfortunately, they are doing exactly what I've just mentioned right now, which is why they're not able to be here. Finally, on rehabilitation financing, so I mentioned, oh no, sorry, I haven't mentioned this. So the NHSU data shows 61% of rehab cases are outpatient. Dorsopathies and osteoarthritis account for these cases, which does raise concern. So the colleagues identified that a strategic vision for outpatient services really must be prioritized. There is a need to clarify the role of facilities outside the capable network. There's a need to manage cases when sanatoriums provide care to patients with severe conditions, and applying functional assessment tools to inform or determine rehab funding is to be considered. And I mentioned that before, and I'll move on to that in a moment. So in terms of the functional assessment tools and the e-health platform, colleagues under the leadership, of course, of Ministry of Health are working to introduce 5 mandatory tools that are available for rehabilitation teams to enter into the e-health system, which is the very beginning of us being able to gather and understand what is happening in rehab beds, because we know right now that the data that we have doesn't really tell a story of the quality of what kind of rehabilitation, etc. So those tools that were elected by the Ministry of Health include the Bartel, the INC, SCI, the Ranchos, Los Amigos, the Mini Mental State Exam, and the HUDAS, which is a more broader disability assessment that looks at physical functioning, but also activities of daily living.
Can I ask you a question now or at the end? Do we know if these tools have been already translated in Ukrainian, validated in Ukrainian?
Yeah.
Yeah, okay.
Yeah. With
So it's just a self-application now.
and actually adding it into the system.
Yeah,
and then, so let's see how we go. I think there may be teams that require training in these tools.
Yeah, sure.
Let's see. Obviously, all of these tools are not relevant for every team. The ranchos, for example, unless you're working in traumatic brain injury, the team is not going to be using this. The Bartel, I think, you know, is the most relevant for all teams, more or less. But it's important to say that this is just from the Ministry of Health's perspective. These 5 tools, just the beginning. They were elected as the most relevant and critical to introduce first, but it will not be the last set of tools that are introduced. Or at least from my perspective, I think the Bartel, we really want to advocate that teams use the Bartel index as much as possible, because at least gives us some data that helps us understand changes in functioning over the most critical areas of activities of daily living for individual patients. But it is a longer road, and we colleagues are really just at the beginning. Patients of Ukraine are developing online training courses for these tools via Physiopedia, and they're going to include them on the NHSU Academy platform, which is really wonderful. It's also just a flag to say that if you and your organization are working with rehab teams, to double check in your needs assessment whether they would benefit from some face-to-face training as well. And of course, this process of integration is being led by NHSU colleagues, and we hope to have those tools available by the end of the summer on the eHealth platform. Okay, it's a lot of information, but of course we will share these slides with you. And on the 2nd of July, we will most likely give another update if anything has rapidly changed with regards to these priorities. So I would just like to pause there and ask colleagues if you have any questions or comments. If Natalia and I are not able to answer them, there might be other colleagues in the room who can, particularly Tatiana, Vitali, but otherwise we can move on to the next session. So
I have a small maybe updates. It's about ICU and acute rehab. I also would add, here was not mentioned in K Partners patients of Ukraine, but my colleagues for 2 last years, we are working on rehab in ICU. It was a study tool, it was a lot of trainings and for TOT, and now it's working on courses, so it's a big amount of work. So it's also taking part in ICU improvement and development.
Thanks, Tatiana. And how do you see the HR coverage in ICU? Like, what would be what's your experience of that? Because sometimes it can be really tricky to have rehab professionals in the ICU. It depends on the facility. Do you have any reflections or recommendations for us on that?
What do you mean?
In some facilities, it depends usually on the doctor. They welcome rehab colleagues in, or maybe they're not super on board or aware of rehabilitation. Or also the inpatient subacute facility or department is very busy. And so it's hard to rationalize or to take rehab professionals from one.
It's problem really. And for some facility, find a way to decide this question, and it's sometimes it's a part of team who work in ICU. Sometimes the mix and change colleagues who work in ICU. Because it's really a part of colleagues said that it's really burning out in ICU. It's much more difficult, and also ICU needs a lot of skills that we didn't have anybody teach us in our universities, and really it's a big gap in university program, and it's sometimes it's not about basic gymnastic or something else. It's advanced moment. And I know that also Norwegian project working in ICU and have a nice Maria can tell.
Yeah, we made a questionnaire after the 6 centers of excellence participated in the Oslo European Conference last year. And we made a questionnaire, how do you think will be the exact benefit after you will be working in Ukraine when you will come back to your hospital? And the specialist told that it was like amazing network, but they are considering this sometimes this is difficulty to work for PT or T with the physicians. Sometimes it's difficult for them to closely collaborate. So we ask if we can help them in this way and make this short clinical discussion cases with the small team, like physician or T and PT, for example. And actually the Dnipro and Ternopil hospitals, they were very active and they answered that yes, we can engage the anesthesiologist and PT in this Zoom clinical case discussion. And other hospitals, they were like, we're not sure that we can include and engage the anesthesiologist into this discussion. So we start this kind of like pilot project with the Ternopil hospital. And now it's really looks really successful because PT and the anesthesiologist, they discuss the clinical case. They cooperate with the Norwegian supervisor, Charlotte, and we see that it's like really good how they are collaborating. And this year will be also the conference on the acute rehabilitation. And the next year will be again this Nordic conference, and they are preparing the research work, the poster that they will share the results of their work.
Brilliant. And this year the conference on acute rehabilitation, where is it?
Munich, Germany.
Oh, okay. Yeah. Right.
It's will be focused on the acute rehabilitation, but also on anesthesiology. So it's mainly, I think, the anesthesiology with the rehabilitation part. But because we include the physician also, so we want to like balance it here.
Please keep us updated on the conference. And you know, there's I feel that there's a need to have please don't roll your eyes, but another working group on acute rehabilitation. Stay with me, I promise. Because this is, we know that there's experts, you know, that are really working on this. WHO and MSF are only, you know, jumping into this now. But there's so much good learning, and I think we need to join forces and consolidate that experiences. We hope to be in Zaporizhia and Dnipro working on this model, but then if there's something that's working really well in Ternopil, then MSF should be talking to you, and then we develop. And so there is a need to kind of coordinate around this specific topic. So we will likely get that started. And I know you have better things to do than to keep attending working group meetings, but please, if it's of interest to you, we won't make them every 5 minutes, but it would be really interesting, and making sure that we're supporting each other and we're learning from each other as this area develops. So thank you. That's wonderful to know.
Can I add something?
Always.
Thank you. So with HR for the past 3 years, we have some capacity building as well in hospital, working with rehab staff who are based in rehab department, but we try to, the aim of the training and the capacity building is about early rehab as well. And we know that in inpatient rehab department, we don't have only patient for early stage. So we try to push the rehab staff to go in other departments, acute ones. Most of the time in ICU, we are more than welcome. After, it's more about how to manage the same number of staff for more patients, knowing that the rehab package is the 3 hours rehab a day. So after, it's more with administration that we have to deal, because the PT are most of the time okay if they feel comfortable, if they receive the training, etc. So it's more with the chief of department that we need to discuss to have an organization who allows a PT or OT to go in the trauma, in the neural, in the ICU department. So yes, the people need to have capacity building and training about early and acute rehabilitation. But in each hospital, we also need to have a clear discussion to know how the rehab staff will work outside the rehab department without having like consequences on the rehab for inpatient rehab department.
Exactly, yeah. And I completely agree. And I think that that's, you know, the same message we continue to hear and see ourselves. And I just want to flag that where at the moment, the health financing team of WHO and Alona Goroshko and Solomia Kasianchuk, who work really closely with our team. We are finalizing the rehabilitation health financing report, which looks specifically at these critical issues. We know that health financing should be there to support the patient, and it should follow the patient. Unfortunately, at this moment in time, it is the other way around. So we've analyzed the packages and looked at how it's either supporting a smooth rehabilitation pathway or creating barriers to patients accessing the rehabilitation care that they need. So that's in its final review, and we hope to have that available by August. So of course you will receive that as soon as it's available. And you know that the other report that WHO is working on and should be released quite soon, we hope, is the comparative analysis, looking at how rehabilitation is financed in Ukraine in comparison to 12 other countries in Europe and including the US. So that will also be available. So for us, that's really a critical area, because I think it's the financing mechanisms can be a blocker, I think, to patient care. So we will update you. Yes, Sinya.
We have a chat and online question. Lesia, please.
Thank you, colleagues. I just want to add that Rehab for You project, we are working also on functional assessment tools specifically for neurological conditions, for SCI, TBI, and stroke. And we are preparing currently for NHSU the document. As you, Marley, mentioned that these 5 tools that you mentioned, they are just the start. And we are preparing a broader list of the tools with purpose and domain of assessment, with administration overview, with scoring interpretation, with psychometric priorities, recommendations for timing and administration of these tools. So it will be such a kind of, I think, comprehensive document to be able to look at it and together make the decision which other tools could be applicable in our country and could be a good resource for the therapists. Thank you.
That's great news. Thank you so much, Lesia. And we really look forward to hearing the updates on that work. That's really good to know. Thank you.
And maybe I will add, Marley, in terms of rehab finance, we as well just finalizing methodology, and we will do the costing for inpatient and outpatient rehab packages for all 3, let's say, packages. So that's work now in the process. So we hope to have the first finding and results by the end of September. So that's as well will be after on prepared as a report and publicly available.
Brilliant. Really good. Thank you. Looking forward to it. Okay, colleagues. Oh, yes, please go ahead.
Я б хотів українською.
And I don't have headphones are in my office, but please go ahead.
Можливо, передати з того, що я хотів озвучити. Я повністю згоден з тим, що є проблеми в доступі спеціалістів з реабілітації до пацієнтів, тому що я як представник спільноти фізичних терапевтів можу більше говорити саме за фізичних терапевтів.
Можна? Я. I would like also to agree that, of course, there is limitations and problems in the access of patients to their rehab, because as a part of assistance of Physical Therapy Association. I will talk mostly about physical therapists.
І ми давно говоримо про те, що було би непогано якось організувати процеси так, щоб спеціалісти з реабілітації вони мали би доступ до пацієнтів в інших відділеннях, не тільки в відділенні реабілітації.
And we are talking for a while already about the fact that it will be nice to organize the processes inside the hospital, that the professionals of the rehabilitation department would have an access to other departments.
Але ще одне питання, яке є не дуже, воно зараз частіше звучить в професійній спільноті, це те, що організація роботи саме реабілітаційного відділення. По чинному законодавству завідувачем відділення може бути тільки лікар.
But what we have more often is a question about the organization of the work inside the rehabilitation department. From now, what we have is that the head of the rehab department could be just the physician, PM&R doctor.
Але у нас є прецеденти, коли фізичні терапевти є завідувачем відділення. І нагадаю, що саме спеціалісти з реабілітації готуються в Україні вже більше 30 років. Тоді як спеціальність фізична та реабілітаційна медицина з'явилася десь близько 6 років тому в нашій країні.
Have nice cases and in general situations when the heads of the rehab department is physical therapists, and just out of the history, the physical therapy education came to Ukraine 30 years ago, while PM&R positions came just 3 years, or from 2019.
І зараз є велика потреба в фізичних терапевтах в різних лікарнях державних. І те, щоб фізичні терапевти або інші спеціалісти з реабілітації, чи ерготерапевти і так далі, могли би бути завідувачем відділення, було б хорошою мотивацією, щоб вони йшли працювати саме в державний сектор. Тому що для цих спеціалістів не так багато якихось таких мотивуючих факторів, щоб працювати за професією. А можливість такого собі кар'єрного росту була би хорошим таким інструментом, щоб залучати спеціалістів.
We still have the need for physical therapists inside the governmental rehab departments, health facilities. And actually, it would be a nice motivation for physical therapists to go to work inside the governmental sphere if they would know that they can have a growth inside the department. It's not a lot of people who are joining without motivation, and this possibility will open doors for them.
Я можна допомогти? І в нас є в нашій країні багато досвідчених спеціалістів, очевидно, що раніше освіта була не такою хорошою, як зараз, але вони мають великий досвід. І це навряд чи вони підуть працювати в державний сектор, але можливість кар'єрного росту могла б бути для них такою додатковою мотивацією в цьому.
We have a lot of specialists who have a lot of experience currently. Of course, if we are talking about education, before it was not that perfect as it is now. However, they have a great experience, and this can push them to work inside the governmental sphere.
Thank you for your comments.
I would add that we talk about this for a long time, and we have in our Congress a big session about this question, and we talk with the leaders in different departments, with PTs. But it's not correct to talk only about PT. It's about all healthcare professionals who have a high education and who have skills to manage. It's a question about everybody, and it would be useful for system to provide such people in leading position. It could be anybody, any profession who could. Who are really leader in team and could do it, have skills, because we know several examples where occupational therapist lead team or somebody else, so it would be normal for everybody give such opportunity, and for several years we're only talking about it in different moments. So
I will agree with Tatiana. So, of course, I understand that you talk in terms of PT side, but that question we raised, we, the society, professional society, raised lots of time, and that's much more right now on the legal aspect. So our legislation developed in such a way, our legal acts developed that really, and it appears at the moment, it creates such a not equality, let's say, in such a way in the team, because for sure, it's not like if you are PM&R doctor, that's not mean that you are the leader, and vice versa. It's not mean that if you are like PT or OT, you will be able to manage the team. So it's much more about regulations and to make this sector like traditions. Yeah, I mean, like it's both like traditionally, mentally, like
mentally is one person who have a high education in our traditions for a long time in Soviet Union. One person with high education in facilities was doctor. And we are something new, and they can't understand it. So I think it's needed time, really, but we believe that it's a normal process, and it must be.
Yeah,
and I would add about ICU one moment. When you talk about an excess of patient, there was a report of National Service. They monitoring acute stroke department, and it was a big financial problems in facility where they didn't find excess of patient for PT and OT. So it's obligation, but they didn't do it. Some facility find a ways, and some facility said that they couldn't, but it's a problem of monitoring of something to help them maybe understand. And sometimes they don't understand what you will be do with this patient. It's not about activity, so it's sometimes these moments. But National Service make some problems financial for them, so it's nice from our point of view.
Okay, thank you. Can I complain a little bit also about their ICU access? Because our project, the project that we are currently implementing together with ICRC colleagues, it's happening in the burns unit. And you can imagine that people who has like the burns of their skin, there is a high level of infection, and ICU is completely closed for everybody. And during this year and a half that we are implementing the project, we kind of realized that there are two problems. The first one is a lack of education, as our colleague said, the mindset of the doctors, a lack of communication between departments. And this is one of the thing that we would like to focus on, the education of the staff. And we are trying to explain the importance of early rehabilitation. We had recently this burns training for 3 days where we were showing the actual results and then the difference of the patients with early rehab and without. And it was so obvious and it was so clear for everybody. So it was great. Another thing is that hospitals in Ukraine, they are mostly like, let's say everywhere, they have very strong hierarchy. And if you really want to break the walls between departments and between the head of the hospital and the different units, you have to start from the administration. So you have to basically to filter down your ideas, but start talking about that. So another part of our work, a major part of our work, is a mindset of administration, and we kind of keep working there, and hopefully we will be there slowly but surely.
Yeah.
Я б теж хотів ще додати на цю тему. Я розумію, що ця тема питання завідувача – це така більш середньострокова, довгострокова задача. Вона навряд чи може швидко якось змінитися, але у нас є закон про реабілітацію, де прописані ролі кожного спеціаліста з реабілітації. І
I understand that the question about the head of the department and the managing positions, it's more like long-term tasks. But we have the law of rehabilitation, where each position has its own description.
І задача кожного спеціаліста, якби вона дуже дуже обширно описана, багато є таких простору для маневру. І це, на мою думку, одна з причин про те, що говорить Анна, що не завжди чітко розподіляються обов'язки між спеціалістами. Хтось там щось собі думає. І я думаю, хоча б прояснити ролі кожного спеціаліста, це не є чимось складним, це можна зробити якось зробити і спростить роботу багатьох реабілітаційних команд, на мою думку.
So about the law of rehabilitation, the task of each specialist and competencies are described in a really wide way. So there is inside space for maneuver. And if we are talking about what can be done, so the roles and responsibilities of each rehab professional can be more structured and described in a better, clear way, and that will ease the work of the rehab multidisciplinary team.
Colleagues, I'm so enjoying this discussion. I'd like to ask if we could please move on, knowing that we have after lunch, we have dedicated time to have these really critical technical discussions, but I also want to have the opportunity for you to hear from our cluster colleagues who have been patiently waiting while I've allowed us to fall behind already, and I apologize for that. But introducing Lisa, the Deputy Head of the National Health Cluster, and of course, Sama, who you met earlier today. So colleagues, it's over to you. I can give you my spot here.
I will stand by the, I'll stand by the, whatever you call this thing, screen. It's Friday, so.
We have amazing partners who are bringing clickers with them.
Oh, wow. You should join the health cluster. So thank you. Good morning, colleagues. My name is Vinnytsia. I'm with the health cluster here in Kyiv, and I came to tell you just a few points about the health cluster and how we work with rehabilitation. So where's the right? So walk along this diagram. It's a bit messy, but it's just to understand how the cluster works, where we sit, and how the rehab working group sits within all of this lovely mess that we like to call the humanitarian architecture. So whenever there's an emergency that the national authorities can't coordinate on their own, they request support from the international community, and the community comes together with different sectors depending on the context. So for example, in Ukraine, you don't have a nutritional crisis, so you don't have a nutrition cluster, but due to the nature of conflict, of course, health is always one of those sectors that requires additional coordination. So WHO is the cluster lead agency, and through the health cluster, we work to coordinate partners who are doing, UC work in the health sector. So where does the technical working group for rehab sits right here? And there's 5 additional technical working groups tasked with providing technical support to partners who are delivering rehabilitation in the emergency context. Of course, this rehab and also MHPSS sits across the spectrum. So it's not just humanitarian work that's happening, as Marley just explained in detail. There's the national health system work that's happening. There's recovery, there's reform. So it's a little bit simplified here. It's just for discussion purposes only. Okay, so this is what we've done last year to help determine how we're going to move as a sector within the humanitarian response. So we all got together. So Natalia is here. She's part of the strategic advisory group, and we planned based on needs assessments, based on epidemiological studies, based on expert opinion. We all decided that there were 16.2 million people that have been affected by the war based on a bunch of different indicators and calculations. Of those, 9.2 million people were in need of health support, and we targeted 3 million, and we said we needed $130 million to get this plan rolling. Then January happened. We had a lovely new president in the United States of America, and who decided that there will be no more money for humanitarian support. So we had to come back together as a group and revise our plans, because no plan meets reality, right? Without, what is it? Sun Tzu says, no battle plan survives a war, something like that. So we're in a war within a war, and we still have the same people in need, 9.2 million, but we reprioritized to 25% of the original target and 25% of the original ask. And what that means, it just means that, so for the health cluster, basically we've said, we know the whole country's been affected by the war, but we just want to focus mainly on what we call the crescent, this the east, the south, and the north. And we said, okay, we'll still keep that for the reprioritized care, but we will reduce some of the focus in cities like Dnipro, places where there's still some support, the government still has capacity, and we'll cut that by 50%. And we know that partners are still doing early recovery, so even some of you are doing these types of activities in rehabilitation, some early recovery that don't quite meet the reprioritization standards, but we know that also people are in the midst of donor cycles, so you're not going to just drop what you're doing because the health cluster said so. So that's kind of where we are. There's a lovely QR code if you want to see. It's quite boring, but it's just there to help us understand where we're also meant to be going. Okay, so next. So now we are at 212 cluster partners, and we have, as you can see, which is quite interesting, in Ukraine, you have more national partners than international partners, which in many humanitarian contexts, you don't see that. That's really good to see. So of the 212, as you have 212 partners who up until June have reached 871,000 people. If you remember, the revised target is 2.2. So I mean, I think that's pretty good. We're half of the year, so I think we're pretty on target. So of those 212 partners, 20 are rehabilitation partners, or it's not, innovation is included. Then of the 871,000, 7,504 are people reached with rehabilitation services. So I think that's also a respectable showing as well. Okay, so this is just a quick coordination slide that needs to be updated a bit, but so the cluster has been, I skipped that slide, but the cluster's been around since 2014. So we're like at the 10-year mark, which is, when you think about it, it's like really insane amount of time to be operational as a cluster, but 10 years. And when the escalation happened in 2022, the cluster was through the entire country. So it's in all 24 oblasts. And as humanitarian finance has changed, and there's been a movement to prioritize resources and to really focus humanitarians to focus on humanitarian work only, you've seen the humanitarian support be pushed more and more to the side. So we're now like back to the present, with all of our humanitarian help assistance. So there's just a quick history of the technical working groups. So trauma and rehab came on about a month after the escalation happened. So it was very, very quick response to what was happening. And we're seeing trauma kits, mobile medical and rehab teams, mapping 5W, who, what, where, when, why, for how long. Not why, but for where, for how long. To prevent gaps and duplication in rehab service and delivery. And that's what Sammy is going to talk to you a bit more about, how the cluster works to support the coordination of activities. Because if you don't coordinate, you will have all sorts, even with coordination, you will sometimes see things that you shouldn't see, but specifically our role as a cluster is to ensure that resources are used in the most efficient and effective way possible. And then last year we did it. So you see there, I think there was like, how many groups that made? Like 14. There was a lot of groups. It was just like a lot of kind of trying to manage the chaos. And then last year we went through downsize, and you see trauma and rehab still remained as one of the key priorities of the health cluster through the revision of the portfolio. So what is the role of the cluster? So we see that there's been a lot of amputations, so the large number since World War I. Trauma and disability cases rising in all populations, specifically in severity 4 and 5, which is the crescent that I refer to. And we are aware that early rehabilitation improves survival, restores function, and reduces long-term dependence. So what the evidence shows is what's happening here in Ukraine is that there's still, like Marley just talked about, there's fragmented rehab services with uneven access between the regions. So perhaps if you're on one side of the country, you have a lot more access than if you're on the other side of the country due to war-related issues. So mental health and GBV-sensitive rehab pathways are not fully integrated, and there's a need for more localized coordinated deployment of trained staff and equipment. So our role is to try to bring order to the chaos. So mapping any gaps in capacity via the 5 Ws or activity info, which Sammy will discuss a bit more, and through cluster coordination. So it happens here at Kyiv level, but more importantly, it happens in the hub. So in the east, in the south, in the north is where all the action is happening, and that's where the coordination takes place. So what we do more on the Kyiv level is advocating with the Ministry of Health and donors to include rehab in the HNRP, the first process, the slide that I showed you that had the amount of people in need. That's a very highly politicized process. And so fighting to keep rehab in where you have non-technical people who say, but is this life-saving? So you have to, try not to jump off of the roof to try to explain to them that this is life-saving activities. It may not, look like putting paddles on people's chests, but it's still a life-saving activity. So that's what we do here, try to keep rehabilitation as a political priority, as well as a priority for raising money. So we also work to support technical guidance through the technical working groups. So you have an army of partners. Many want to do whatever they want to do. So we're grateful to Marley and the group to keep them on task to ensure that at least there's a standard of service that everyone can receive. Like you shouldn't get a different standard from this mobile medical unit than the other. So that's the role. One of the roles of the technical working group is to ensure that there's a harmonization, that there's internet minimal standards are met, and that there's best practices that can be communicated throughout the community, and also supporting referral through intercluster coordination at national levels, so working with protection, through GBV, through child protection, through all of the other clusters that kind of complement the work that's done at the health cluster. So I think that's it for me. Oh, great. So coordination successes. We put superhumans here. Like it's WHO, but it's also because we coordinate the rehab working group. We thought we put that there. That's definitely been a great success. It's something that Health Cluster and WHO and partners have supported. Referral pathway strengthening. So trying to facilitate linkage between trauma care, rehabilitation providers, mental health services to ensure the continuum of care. Us working with local NGOs, so supporting national partners with rehabilitation coordination entry points, 5W activity info. Also supporting local partners with resource mobilization. So Marley's discussed the Ukraine Humanitarian Fund. So we do work with partners to try to make sure that they're able to receive funding and carry out this work. And finally, donor advocacy. So positioning rehabilitation is a core component of humanitarian health support. So really trying to change the mindset of people that rehab is just an add-on, which is what a lot of people tend to think. They're not health specialists or they won't understand. So really trying to help them to understand that this is life-saving support. So I think that's it for my side. I'm going to pass over to Samit. And I apologize, I have to run because I'm on a deadline.
Thank you. Thank you, yes, for waiting for us.
Yeah.
Okay, so like numbers, this is what you will see in the coming 5 slides. There are only 5 slides. If you recall one figure from this presentation, the 7,500, those are the 7,500 people we will talk about. And if I manage to work with this one, yes, people. So, just few, let's say, disclaimers. The data you see here is the data that we received as a health cluster reported by most of you. So this is your data. Second, it covers all over Ukraine because we know that most of you are operational in more than one part of Ukraine. That's why we didn't keep only the priority oblast, but we put all the data that we have from you. And if you can see very quickly, you see that most of the reported reached people are in Dnipro. And by Dnipro, we mean Dnipropetrovska, Zaporizhzhia, Donetsk. Then followed by Kyiv, which covers also Chernivtska, Shinska. Lviv, Vinnytsia is like central west part of Ukraine. And Odessa is a southern part, Odessa, Khersonska, Nikolaevska. So this is, it gives you a bit how far the 7,000 people are distributed. Then, here I link a bit to what Lisa touched on and what Mari also mentioned earlier. Based on the data I have, I make my own assumptions that they might be wrong. So if I look at the data between January, February, March till May, I mean, this is the 5 months data that we have, I don't see much of financial impact on the activity. Because it's normal that on January, you don't reach your max because it's the starting of the year. So you're setting up. So fair enough. February, better. March, even slightly better. April, fine. May is the highest. So if I look at this data in terms of numbers, I can easily say funding is okay. Partners were not impacted by the US cuts or any other cuts, at least for the 5 months. Would you like to debate it?
But it's January. What about December 2024?
Yeah, I mean, we could compare it to Q4.
In January,
it went a bit down.
So it's already cut, you know?
Like lower than the last year. I mean, that's an interesting comparison to do. I mean, we have the data of last year, so we can also do this exercise, but I put it mainly to not to challenge, but just to show, like, based on the data, I cannot say rehab partners were impacted financially by January, February, based on the figures I have. But wait a bit, because the next one is the more we report, the better picture we capture. So I also assume that there are some figures or partners who are not reporting, let's say, regularly. I totally understand that you are asked to report maybe on 2 different platforms or 2 different ways. And our activities are quite basic and simple, while you would like to go into more technical data and technical activity. So I understand also that we don't want to overburden anyone, but here is just to show a basic of who are the, let's say, the top 20 partners that Lisa shared already in the previous slide, and how many they are reaching over 5 months. And here I'm still asking, are we under-reporting? Like, is any partner is under-reporting somewhere or not? If you see Caritas data here, I know it's outstanding. You may want also to ask. I mean, I'm not sure if we have anyone from Caritas in the room, maybe online, but my simple understanding why it's quite high, it's because here it's Caritas Ukraine. It's not Caritas Oblast level, it's all over the Oblast. So the 24 Oblasts are reporting under Caritas Ukraine, while maybe not every partner in the room or online is working in the 24 Oblasts. So it gives a bit of reporting scale. Second, also, I'm not sure that all the partners started implementation in January. Maybe you started in February or started even in May. So it's just to show a bit like how and who are reaching the most of the people out of the 7,000.
My laptop is here and it's.
I'm sorry, I'm sorry. Okay, then if you recall that Lisa said something called activity info, it's like the platform where all the partners are reporting to. You report on Excel, we put it on a map. Okay, so we have three sub-activities where you provide rehabilitation and physical therapy mainly on inpatient, outpatient, or community, if I want to use the same terminology, use it. Or you do cash voucher assistance for rehabilitation costs, so you facilitate access to rehabilitation services using cash or voucher, or you do trainings and capacity building for the healthcare work. Could be at any level. So I know we discussed the ICU part, but can be also anywhere. So if you look quickly, the most, let's say, achieved activity is the community part. Let me say community part because I have the breakdown, and most of those activities are done at the FAB level, so the furniture aquaculture kapung somewhere, or at a school, or at home-based care. So that's why out of the 5,000 or 4,000, and you will see the difference why, that's done at community level. So if you are worried about your community level, I mean, apparently community level works here on the day. CBA, cash voucher, we have around 900 people who benefited from the cash and voucher. But the point here that I want to reflect on is that if all of us in the field are aware, where is the next accredited facility where the NCSU batch is signed to where we would like to refer our patients. So just to make sure that when we refer using cash or voucher, we refer to the accredited or approved healthcare facilities, and that's already available online on the NCSU dashboard. So you can play with the dashboards, you see which hospital is contracting which package. Let me go back to the two different numbers. Basically, why I put 4,000 and not the total of 5,100, it's because there's a lot of others. When you ask about the location, you put others. Mm-hmm. And then after others, you have a space to clarify. Others is a school, others is a FAB, others is a house, others is a community center. Others can be many, but some still keep others. You don't specify what's others. So that's why I just wanted to show like how many we're missing really to know the locations where you work. Back to the question of children, because it took also a bit of good discussion. I did a quick search in the data. Out of the 7,500 people, we're talking about 1,200 children. It's quite a lot. Mm-hmm. And I think it's mainly related to the community part. You go to the house, you go to the school, you go to the transit center where the kids are. So that's why you are reaching quite well if we talk about kids. And the most challenging slide, the last one. Now we talk. The question is, every person under rehab care has a disability. Is every person? Why I'm asking the question? Because we do the disaggregation by men, women, children, adults, elderly, but also people with disability. Mm-hmm. And you gave a figure of people with disability around, I think, 2,200 out of 7,200 for simplicity, which is quite high, which is fine. I believe it with this breakdown per oblast, with more people with, let's say, declared disability in Dnipro, followed by Kyiv, more or less it follows the reach that you reported there. The point is, how do you report the person with disability?
Good question.
How do you report it? The answers I know at least, or like my colleagues told me from the Rehab Working Group. Either the person has a certificate that he or she shows, so then you count as persons. Or you use the Washington group of questions, then based on the score and the result you declare, like you record a person with disability. Or it's your own assessment as teams in the field. I think Sam is with disability, so I will put him as one person with disability. Or this is how the person perceives himself, herself, or declaring. So that's why for me, I know there's a lot of things about certification of people with disability, the levels. So here it's just to show like, not everyone who received rehab is reported as a person with disability. Some of them are, and HI will tell us more.
Yeah, no, this is a very good question, because when I arrived in Ukraine with HI, I was like, I don't understand why we don't report 100% of our beneficiary. Basically, based on the definition, a person with disability, it's on a long-term disability.
Yeah.
So for HI, for example, person with disability, we follow this definition. which for some of our beneficiaries, it's not true. They are facing a situation of disability, but in 3 months, they will be fine. So now we have person with disability and person facing a situation in disability. To know the percentage and to know more, but that's true. For me, it was surprising. On my practice, everyone is a person with disability based on what I see. But when we follow the definition, it's not.
Yeah, I think that's, again, great question. And back in my former life as a disability advisor in protection, I can say implementing this and disaggregating disability data was so much easier. It is the most difficult to have this conversation in a rehab sector, right? Particularly at WHO. But anyway, I would say like the Washington group questions, they were designed to identify people at risk of disability in a humanitarian context, right? So I don't think it's our job to say this person has a disability, this person doesn't. All we can really do as humanitarian actors is identify people at risk of barriers because of one or more functional impairments, regardless of how long they experience that. So if you have a patient or someone you're working with and they have a broken leg and you know in 3 months they'll be fine, but for now they're non-weight bearing, they're going to experience barriers when they go home. They might not be able to get on and off the toilet. They might not be able to do their shopping. And that's a barrier for them. And it puts them at risk of deteriorating health, of social exclusion, et cetera, et cetera. So my recommendation would be is to let's stay in our lane. And when we talk about disability, we're talking about function and access barriers. And so for us, this is how we see it, because we can't judge actually, and we're not the MSEC, and we're not, and often we don't have the resources to really make an in-depth judgment or conduct a WHODAS assessment, which takes 45 minutes. But I think from the cluster perspective, what's really important to know at a national level or oblast level as well is how many people are at risk of exclusion or protection violations or health deterioration because they're experiencing barriers based on function. So for me, this would be sort of the best way, and it keeps it really clear cut. But it's important to note that when we use the Washington group questions method, part of the critical part of the methodology is you don't use the word disability. It's a risk of barriers. So that also sometimes confuses things, because then people say, oh, well, they said cannot, a lot of difficulty or cannot do it all. They're a person with disability. No, they're at risk. Similar in a way that we identify women and girls, and it's may or may not impact, their health or whatever, just because they're a woman and a girl physiologically, but we recognize that they are at elevated risk of certain protection violations purely because they're a woman and a girl or a military aged man. So we try and look at disability not super from that biomedical model, but how that impacts their ability to function when they go home for however long that might be. Yeah.
So I really had a lot of discussions about it also with the Washington group, but then we have to make sure on how we use this number of people with disabilities. Because if we say, okay, so I will report that a person has a disability if I see that it has risks of accessing support, accessing social opportunities, etc. So I would report it as a person with disabilities, and then we might have the health cluster or the government that uses the number to say, these are the people with disability. In Ukraine, we have these amount of people with disability, but in that amount, you have people with a fracture. So that in a long term. So we have to make sure that how we report is also how the numbers are used.
because there are always these differences between the health and the social department. We have this discussion also upstairs, what the health consider disability, what the social department consider disability. And so sometimes when the social department uses the health numbers, we are actually talking about different things. So I think that, and this is also one of the reasons I think we're here, we can agree on how we want to report. We report on very like difficulties in accessing, but then we also have to make sure that the numbers are then correctly used and not used to advocate for we have this amount of long-term disabilities, because that wouldn't be true.
Yeah, I think it's a good point. I mean, the Interagency Standing Committee guidelines clearly state, you know, that you use the Washington group questions to identify people at risk. And I think it's a really good point, because we need to be clear, why are we asking? Why do we care how many people have disabilities in emergency areas or areas of the country that's in emergencies? We don't collect the data just because we want to have fancy figures and talk about it. We collect data on disability because then we take that data and say, okay, we have X amount or X percentage of people who have mobility issues. So if I'm doing a food distribution, or if I'm setting up a primary healthcare facility, I need to think about universal accessibility of my project. Or if I'm seeing a lot of people have problems with communication, then I need to understand, how can I reduce the barriers, communication barriers for people, so they can come to my project, if it's health, if it's protection, if it's WASH, whatever. So that's really why we collect that data, right? And then I think how we communicate that, I completely agree with Maria in terms of, you know, we in the cluster where we're not disability experts, we need to know who our population are, so we can program the best way possible for them. And that's really the point of collecting the data, I think. And so that messaging towards government focal points, I think, is really critical to have that distinction.
Molly, can I make one more comment from protection cluster side? I think in support of your argumentation.
Hello.
Hello.
Please come in.
Yes, thank you. I think what also underlines the importance of the Washington group questions is the fact that from legal perspective and among protection partners, you will know we have some of the partners who provide legal assistance, and many of them focus on supporting the people with disabilities of obtaining the documentation that allows them to get the certification. And this process is very time consuming. It's a complex process, and you will know better than me, for the organizations who work so closely with people with disabilities. But in order to get this certification, it takes sometimes 6 months or even more. So that's why I think we need Washington group questions, and precisely from protection perspective, it is more important to answer the question, who's at risk, and that informs really the programming. Back to you.
Thank you, Kasia. And for those who don't know Kasia, the lead of the National Protection Cluster, thanks for being here. I'm sorry.
I am learning a lot. Thank you so much.
Back to you, Samuel.
Thanks a lot. I'm also from the protection cluster, so I'm taking the opportunity. I'm taking an opportunity of having a lot of health actors in this room, including those who are familiar with the state system. So my question is the following. In your activity description under rehabilitation, you also mentioned home-based care. If we go to the Ukrainian legislation, it's purely social protection service, which is regulated by which is established by the Ministry for Social Policy. And if we go to the description of this service, it's saying like supporting in home staff, referrals, navigating bureaucratic complications of Ukrainian system, etc. So they do not look like health activity. So the main question is, what health actors are doing under home-based care? Whether this activity aligned with the global standards, or they are also regulated by Ukrainian legislation. Maybe Ministry of Health also has such service like home-based care.
So what is the vision on this? How to delineate like home-based care from protection? Yeah, exactly.
You can go. Yeah.
You want to go first? I will give the cluster, let's say, definition sort of. The point why we consider it also as a health activity and we ask partners to report it first, because most of those mobile teams are multidisciplinary. So you have a medical doctor, you have a nurse, you have a psychologist sometimes, and social worker. So the visit, I agree, there's this community part, like I take care of the garden of the person, I help the person to have everything he or she needs, but there's also a medical part of it, like taking the blood pressure, taking the vital signs, doing some mobility exercises at home. So there is the health-related part, not only the social taking care of the person's life. I visited like 3 partners doing the, let's say, rehab and home-based care. And this is how I saw it happening in the field. Like one of them was the Norwegian Red Cross, who's URCS, who's the British Red Cross. And this is how the idea was. The person is already an old person with a stroke. Like this is from the field. So the person is checked on his like NCD condition, plus doing the session for keeping the bulk of the muscle, keeping a bit of mobility. So this is how we categorize it more under health and not only under social protection when we talk about home-based care. This is from how we saw it through partner visit.
Yeah, thanks, Sama. And just to add, I think with regards to legislation from the health side, and other colleagues who are more expert in this space than I, please come in. With regards to rehabilitation, there isn't a home-based care service available under the Ministry of Health. What there is available is palliative care, and this can be delivered in the home. And this is an NHSU-funded service. However, it's important to note, especially for the internationals, that in Ukraine, as I understand it, and please, colleagues, correct me where I go wrong, is that palliative care is in the legislation and in practical provision is a very broad stroking process. I'm from Australia. We call palliative care a service for managing people in the end of their life. So they're actively dying. In Ukraine, it's a much broader package. So this often people receive a palliative care visit from a nurse, for example, and they're managed by their primary healthcare physician because they are profoundly impaired in one or more of their functions. They have comorbidities. They're quite unwell, but they're not actively dying. And so this is maybe where we could envision the cluster definition of home-based care within the health sphere. Of course, I'm a rehab brain. There may be other NHSU packages that enable home-based care, but the one that we come into contact the most is this palliative care in terms of it's provided to people in the home, and that's a health-based service, and it's typically nursing.
That's interesting point. Thank you. And thanks a lot, because from what you described, it like looks like humanitarian operational approach, which completely makes sense, like mobile teams with multifunctional specialists. I mean, my question just based on the legislation, and I just checked the standard before asking question, and it's really focused on social protection, not on health. And it's provided by social worker who not necessarily has like health background. So that's why for me, what was important, like the reading of this service by the health sectors. Thank you.
So I'm done with the presentation, and we have data up to the facility level, but for sure I couldn't do it here. So if you need any specific information about data or partners presence, you can go through Xenia, through the Rehab Working Group, and we will share the data with you based on your request. Thanks a lot, and good to be with you.
Thank you. Thank you. Thank you. Wonderful. Okay, colleagues, how are you all feeling? We've been in this room for
in an acute ward every 2 hours. You need to have repositioning.
Shoot. I think it's a real good point. I apologize, colleagues, because my timekeeping today has been abysmal. So I apologize for that, and thanks for your patience. But also, these conversations are so rich and, you know, so useful, and it's just such a thrill to see you face to face. So thank you. So let's have a quick break. Okay, get some fresh air, do some stretching, as
tea, coffee.
Sonia mentioned, tea, coffee. And maybe we could do just a 10-minute break, and then we will have lunch not long after, so we won't imprison you in this room for as long. Thank you. And thanks, colleagues online. We'll see you shortly. We're going to welcome Senya and Maria, who is online, to talk to us about the rehab workforce assessment. Then we're going to hand over to Yevgen to talk to us about their project in strengthening rehab in Vinnytsia. Then we will go to lunch, and then we will come back and we will hear from Vladislav from the Rehab for You consortium. So Senya, over to you.
Yeah, thank you. Well, just with Health Cluster together, we decided to make a break at first, but I have a really fast presentation regarding the mappings that we've been working on. And finally, from today, we have also divided all the mapping of partners to the level of hromadas. So currently, we can see, according to Health Cluster reporting, in what hromada our partners who are reporting to Health Cluster are working. And of course, on the map, you can always isolate just one hromada and to check what's going on inside. We can see information from the beginning of 2024, and we've added recently months of reporting till May. And also on the hromada isolated level, you can see what partners are present in this location. So it will be easier to orient right now in the space. And of course, in case you will need any contacts, you can always reach me and I will provide you emails of partners in order to connect you all together. So I hope it will help us to find connections and to work more effectively. And in general, those partners who are not yet inside the health cluster, you are more than welcome. If you would like to report, all your data will be visible, and you will be able to find more partners in case you're reporting or putting dots, because the reporting, it's not that hard. We have health cluster tables that you will be able to fulfill every month. And there is disaggregation by the oblast, city, rayon, hromada, what hospital, and how many people reached. Unfortunately, we are not yet including the topics of the trainings that are being conducted, but you can always reach a partner and to ask what was the activities performed in this or another hromada. I will be sharing this mapping too on July 2nd. Because currently some codes are jumping and sometimes we can see some problems and they jump out, and some areas can be that are currently occupied are being reported, but we will fix this bug really shortly. So yes, this is about partner mapping, and everybody is more than welcome to join. And I am opening our presentation with Maria Ramiro, and I hope she is here. Maria, can you hear us?
Yes, I can.
That's
Can
perfect.
you?
Yes.
Okay, let's go.
Also, you to be visible. Okay. Yeah, okay. Now we can hear you and we can see you. Perfect. Please tell me when I will need to change the slides.
Okay, perfect. So I will be very brief because I'm very aware of the time and the amount of information that is being shared here today. And just to say that I'm really happy because the amount of information is going to help us a lot to add to the growth, to the rehabilitation evaluation in Ukraine, and definitely to be aligned with all your activities and all the proposals that you are implementing. Senya, let's continue. Just a very fast background of the evaluation of the rehabilitation workforce. In 2020, WHO provided a technical support for the Ministry of Health of Ukraine and the Ministry of Social Policy to give a complete evaluation situation of the rehabilitation in Ukraine, including the assistive technology situation. as you can imagine, these years has passed, and then in 2024, it was decided to repeat the evaluation, as you know. So there was another evaluation of the rehabilitation situation in Ukraine. And as far as I know, Marley, correct me if I'm not okay, the report is not yet published. But what we already know is that there was very important information about the rehabilitation workforce, and it was like that it's been expanded a lot from the 2020 evaluation. And there's not a clear situation of the rehabilitation workforce in terms of education and training, labor market, and quality of work. And I'm being listening to you, and I can see that the situation is as such because of the ideas and thoughts that you are sharing here. This evaluation of the rehabilitation in Ukraine recommended conducting a detailed evaluation of the rehabilitation workforce, and the guide for rehabilitation workforce evaluation, GROW, was a tool selected for such an evaluation. GROW, and I'm not gonna spend more than seconds. GROW is a systematic evaluation of the rehabilitation workforce, which goes deep into factors that might not be taken into consideration in a comprehensive evaluation of the rehabilitation situation in a country. I was the responsible for this tool in the rehabilitation program in WHO headquarters, and that's why I have the privilege to be here supporting this evaluation. Senior, the next one. Concept. What is the guide of rehabilitation workforce evaluation? Is a process for the evaluation and planification of rehabilitation workforce. So it's very important. We are not only collecting data to see how the situation is, but we want to give tools to facilitate a planification of rehabilitation workforce that is even more important. And at a national level, we are not doing it in a regional part. And the main focus of this evaluation is towards effective coverage. What is effective coverage of rehabilitation workforce? And this is the key of our efforts to collect information. It's a situation where the population can access, and you've been talking about accessibility, and use the rehabilitation workforce to effectively meet the needs, the rehabilitation needs they have. So this small sentence has so much meaning, so much knowledge, and that's why we are going very thorough to get information, because our goal is to know about the effective coverage of the rehabilitation workforce in Ukraine. What are our objectives? This is like always, evaluate the state of the rehabilitation workforce, identify actions that could improve the situation, this effective coverage, establish recommendations, and finally, with these recommendations, elaborate an action plan. All these, as you can imagine, with the collaboration with the coordination of the Ministry of Health and the institutions in Ukraine and other partners. Senia. And just to mention who are for us the rehabilitation workforce in Ukraine, because you have to decide who you are evaluating. It was decided that the evaluation was going to be for the groups included in the Article 10 of the law of Ukraine about rehabilitation in the field of healthcare. That law was elaborated in 2020. And they are the assistants of physical therapists and occupational therapists. They are in alphabetical order, so this is how it's going to be throughout the discussion. Occupational therapists, physical and rehabilitation medicine doctors, physicians, physical therapists, prosthetists and orthotists, psychologists, rehabilitation nurses, speech and language therapists, And there is one more occupation that was not included in the Article 10, but definitely is fundamental for the rehabilitation support for the population, and these are the social workers. And they are included in the Article 18 of the same law as members of the multidisciplinary teams that are working in the rehabilitation institution. So Article 10 for the majority plus Article 18 and social workers are there. And we could talk about the specificities of collecting information about this occupation later, if you consider it. Senia. And I'm just briefly gonna tell you what is the process, how we decided to go through these complicated tasks. And is, as Gro indicate, is a systematic way. We go through a system of collecting data. How we do it? Desk-based data sources. For us, because of the situation of Ukraine, it was extremely important to know about the laws, the norms, the orders, everything that is being developed there, to be able to understand the situation and to be able to write something that is according to the law and not out of good intentions only. We also consulted the health and education information system. Quite a bit of information is free, so you can consult it. Then we are reading about the situation, general situation in Ukraine, demography, economic, politics, to put the rehabilitation workforce into context. Key informants and key people here. Well, first, we have the project officer of the evaluation, is Senia, a beautiful colleague that you have there with you. And then we have many colleagues that are who are helping us to collect information. The rehabilitation workforce task team is the group of experts in each rehabilitation occupation who are giving us very valuable information about how the situation is in Ukraine through personal experiences, but also being able to extrapolate and give us a view on how the situation for this occupation is in Ukraine. We will discuss with the education system, because it's one of the key factors and sectors for the rehabilitation workforce will be the education one. And then we will have key informants, key focal points from the Ministry of Health and other ministries according to the information we need. And then I have to say that we have technical support from WHO country office, development partners that we are starting to talk with. And when the report is a little bit developed, we will have peer reviewers to give us expertise. And now I want to just say thank you to Veronika Szepkowska and Maria Lipochenko. They started this from the beginning, this evaluation from the beginning. And then Pablo Kadaner and Volodymyr Golik are giving us great support, and because of the comprehensive knowledge they have about the Ukrainian system, health system. So it's worth it to mention that they are doing great for us. And definitely Marley is overarching and helping us in everything she can. And so far, how are we organizing it? We are having meetings, 2-3 meetings a week. Senia and myself, sometimes with the other colleagues from WHO country office. The rehabilitation workforce task team, we are meeting them several times till we saturate the information. We are gonna continue talking to them and getting information. And basically the rest is searching, digging for information in the net. And so far, what is the information of the group of information we are collecting? One has to do with the population needs, and you were talking about disability, persons with disability, person with temporal situation of disability. So we need to know who needs rehabilitation, whether you have disabilities recognized, certified or not. We need to know what are the rehabilitation needs of the population, and based on that, we can organize and plan the rehabilitation workforce and where this rehabilitation and who should be in which place. For this, we are collecting the number of people with a proxy of the number of people with rehabilitation needs based on certain health conditions that are already known to be needing rehabilitation. We are still waiting for this information. Then the supply of the rehabilitation workforce. We are collecting the number of rehabilitation workers that are in Ukraine. And then we are collecting data in the education and training sector programs. The programs themselves and the number of graduates that are coming from these programs is giving us very rich data and data to think about. Then the demand, the number of workers, rehabilitation workers that are already working in the institutions, and also the job offers, if we are able to get this data. And finally, we are collecting data about quality of work, quality of the rehabilitation workers, because it's one of the key factors to finally going for this effective coverage. And I think Senia, I finish here, right? Yeah. Just thank you very much. If you have any information, anything you want to share, any thoughts, just be in touch, get in touch with Senia and Marley, and we will be so glad to have meetings with you. Thank you.
Thank you, Maria. But if you will have a wish to jump in during my presentation, please, you're always welcome, because you know even better about the challenges. So when you're thinking what takes us so long to get and analyze the information, the biggest question is the information that is available, the quality of it, and of course, rapid changes. So one of the biggest challenges is a rapid policy change inside the Ukraine, because when we are starting to analyze the professions, we have not just rehabilitation nurse, we have physiotherapy nurse, we have massage nurse, and inside one occupation, there will be different specialists that were working, currently still working, and will be probably working, and we don't know for sure. That's why we need to analyze everything. Also, education, for example. Before it was specialization of physical therapy and rehabilitation. It was also physical rehabilitation. Now it's divided for occupational therapists and physical therapists. 2 years ago, it was specialization called 2 to 7, but this year specializations are also divided according to the field, and physical rehabilitations now is in specialties, I don't know how to say it, specialty, I7. So we need to include both previous experiences and past experiences, because we are making analysis of the situation 4 years ago and now to see the changes. Supply number of workforce, NHSU numbers and reality. I will show you a bit later in the slides. However, all those professionals who were receiving education as PTs and OTs together after graduation, and we see the general number of those who entered education, of those who graduated, and then they went to work to different fields, or sometimes part-time in one field, part-time in another field. So we don't have clear information regarding that. Private sector workforce. You don't need a license to work as PT in a private sector, or to go to work at home, for example, or to provide private service. That's why we cannot understand correct number of those who is working privately. Education of the workforce. As I've already said, it's PT-OT joint program. However, it's not just this. It's also entrance to profession criteria. As you all know, to become assistant PT or assistant OT, you need 4 years of bachelor. But also it can be 3 months specialization after nursing to become assistant PTOT, same. So we cannot say that it's equal entrance to the profession. And also, it's also hard to identify the numbers of professionals who went through specialization. But we will be also asking for support from us, associations and working groups, because we know the numbers of universities who is providing this specialization, but probably we will need to contact each of them directly to know the number of graduates. Because inside an HSU data, we can see just the list of assistants OT, assistants PT, and it's not clear who is who. And just demonstration, professions. We have codes for professions, but we have old codes and new codes. We have assistant of physical therapist, and we have assistants of ergotherapist. We have massage inside of this, and we have professional from physical rehabilitation. This all is still inside the Ministry of Economics profession codes. About nurses, we have nurse of rehabilitation, massage nurse, nurse of physical education, nurse of physiotherapy written together. So we are also including inside the analysis those professions that were before inside Ukraine. We have a physiotherapist doctor, we have physical education doctor, and we have doctor of physical education and sport medicine. So this is one of the challenges. Regarding the workforce, when we started to analyze the numbers, we got the numbers of the active workers currently registered inside health facilities and contracted to inpatient package of an HSU. These are beautiful numbers, and seems like we have so much workforce working in the healthcare facilities. However, that's not the case. And if we are open NHSU data and we are checking the number of the diplomas on the right, we can see that people with the same diplomas can be registered in 4 positions. For example, here is the same person who is working as ergotherapist, physical therapist, ergotherapist, and physical therapist inside one health facility on 4 positions. It's hard to diversify. And if you think that I found just a small part, no, we can all the numbers that are not being unique. So basically, it's not a lot of people who are taking a unique position, and it's all over the file. Yes. Then, yeah, we have for some cases the aggregation of the ergotherapist and nurses. So sometimes we can see, sometimes we cannot. Oh, this is the next slide. I'm sorry. Yeah, so checking NHSU data, for example, I opened the money received during January 2025 in huge sanatorium. We will say the name, but probably a lot of people knows about it, and they received 10 millions. And you may wonder, wow, probably they have a lot of workforce inside the health facilities. Yes, okay, they have 29 PMNR doctors, 21 PT, 22 SOTs, 35 assistants. But you open isolating this health facility and you see that a lot of positions are being covered by the same person. So it was a short monitoring of an HSU performed by us. And in this case, we have numbers to compare. And as you can see, numbers 5 years ago, they were really low, but there was no duplications. And for now, I calculated just fast, and it's not precise information, but the numbers of the diplomas duplicated are increased significantly. Yeah, And this what the slides talking about, these health facilities, which is getting 10 million per month, but we can see that assistants OT, assistants PT, ergotherapist, even doctors of physical and rehabilitation medicine, all 29 that are inside are duplicated. Yeah, so that's are the biggest challenges that we have right now. Of course, we will have more challenges further because we will start to evaluate also private sector. Also, we need to evaluate the people who were transferred inside the country or exited the country. Basically, the immigration and the emigration of the health professionals. But in an ideal world, it would be we will be able to find this data. I don't know. Maybe we will not succeed. However, we are trying hard. And of course, there are some professions that are just coming to light, like speech and language therapists. We will not be able to analyze what was 4 years ago because just this year started the first specialization program. So we will be analyzing logopeds, defectologists, and 5 other professions that we will need to describe and to come to SLT profession. So it's a lot of points that we will need to cover. But in case you would like to share your opinion or you have some information or you want to share the things that should be highlighted as a problems in future, me and Maria, we will be happy to get your experience and your opinion, and you can always get in contact with us. That's all from my side. Thank you.
Thank you so much, Senya and Maria. Great to see you online. I'm going to move us quickly and hand the floor over to Yevgen for the final presentation before we move to lunch. But if you have questions or comments, please save them for the lunch break and also our dedicated session after lunch. Over to you, Yevgen.
Presentation, sorry.
Поки запускаємо, колеги, мене звати Євген Прилипко, як я представлявся, я керівник експертної громадської спілки, консорціум експертних груп Healthcare Transformation Forum. В контексті того, що зараз говорила Ксенія, у мене теж будуть деякі не дуже оптимістичні цифри. Але, тим не менш, я маю презентувати і представити один з проєктів, інфраструктурних проєктів, які ініційовані Міністерством, точніше підтриманий Міністерством охорони здоров'я України за фінансової підтримки міжнародних партнерів. Мова йде про проєкт реконструкції реабілітаційних центрів у Вінницькій області. Проєкт фінансується в межах міжурядової гранти між Францією та Україною.
Він був тут.
Францією та Україною він був підписаний в жовтні 2024 року. В рамках цієї угоди Франція виділила 15 мільйонів євро спеціально для покращення реабілітаційної інфраструктури. Тому проєкт фокусується на реконструкції 2 закладів охорони здоров'я у Вінницькій області, про що я скажу пізніше. Хто залучений до реалізації? Безумовно, це Міністерство охорони здоров'я за активної підтримки обласної ради і обласної державної адміністрації, я би так сказав, навіть активного втручання. Французька сторона фінансує проєкт через спеціальні фонди України, що дозволило залучити французькі компанії, відповідно, ви їх бачите зверху, Ellipse Projects і Ginger International. Саме завдяки Ginger International ми завдячуємо цьому проєкті тому, що з'явився додатковий цікавий компонент, про який я більше і розкажу. Через це ми в своїх комунікаціях застосовуємо іншу назву проєкту – це зміцнення реабілітаційних послуг в Вінницькій області. Сама команда експертів HTF, організацію, яку я представляю, відповідає за цей компонент додатковий. Один – це реконструкція, модульне будівництво, оснащення, а другий компонент – це безпосередньо зміцнення реабілітаційної мережі, технічна підтримка та підвищення спроможності надавачів послуг. Ну, мовно кажучи, ми так домовилися, що якщо ми будуємо і оснащуємо, ми хочемо подивитися, наскільки ефективно будуть працювати і можуть працювати ці заклади охорони здоров'я, використовуючи те, що було проінвестовано, неважливо за які гроші. Відповідно, ці якісні послуги мають бути і ефективними, результативними для пацієнта, заклади мають бути фінансово стійкими, мати стратегічний план розвитку, ну, якнайменше 5-10 років, мати старт-план і так далі. Як керівник організації я входжу в робочу групу, відповідно, з реабілітації, і так само моя функція координувати ці зусилля, уникаючи дублювання зусиль і ділячись інформацією, і щоб це було в контексті стратегії розвитку системи реабілітації в Україні. Як я сказав, це два заклади, регіон, 15 мільйонів і 16 місяців реалізації цього проєкту. Тепер щодо безпосередньо самих закладів. У Ладижині це повна реконструкція санаторію, який, безумовно, з укриттям, і планується розміщення 3 основних відділень. Це, відділення ортопедії і реабілітації, неврології, неврологічної реабілітації, профілактики професійних захворювань. Це приблизно плюс 46 людей. Хочу зазначити, що це загальний заклад охорони здоров'я в нашій спроможній мережі. Так? Ми розуміємо, що є у нас кластерний не так далеко заклад з реабілітаційною допомогою, де має розвиватися реабілітаційне відділення, але не так далеко ми будуємо і робимо і запускаємо такий великий проєкт. У Вінниці будівництво буде складатися в дитячому реабілітаційному центрі для дітей, будівництво модульних блоків. Відповідно, це стаціонарне відділення на 24 плюс ліжок, про це окрема історія. І амбулаторний блок фізичної реабілітації та психологічної реабілітації для дітей. Відповідно, і там інфраструктура передбачає укриття. І, наприклад, в Вінниці ми вже порахували, що це приблизно 300-310 людей, і це достатньо великий виклик, оскільки це і спеціальні умови для дітей, їх розміщення, ДЦП і так далі. Тобто це окремий навіть проєкт, це окреме медичне завдання і завдання на проєктування. Це щодо безпосередньо самої інфраструктури, а тепер про компонент. Про те, що ми сьогодні багато говорили, і про фінанси в тому числі. Компонент зі зміцнення реабілітації мережі технічної підтримки та підвищення спроможності надавачів послуг, він складається з наступних пунктів. Я дуже швидко проговорю. Це технічне планування та проєктна підтримка. Це те, що відбувається вже зараз, і старт вже почався. Це розробка медичного завдання та завдання на проєктування, аудит проєктної документації, на відповідність критичним, функціональним, інформаційним вимогам, санпінам, нашим ДПНам і так далі. Для наших міжнародних партнерів це суттєвий виклик для того, щоб це робити. Фінансова стійкість і ефективність послуг, це аналіз витрат, фінансові розриви, моніторинг показників ефективності для обґрунтування управлінських ресурсів, управління ресурсами і так далі. Далі інституційна спроможність управління ресурсом. Це було. Ні, вибачте, це оцінка кадрів, те, що ми вже говорили, операційної спроможності, підтримка стратегії розвитку, брендування, сталість і фінансова стійкість закладів охорони здоров'я в майбутнє. Запуск, навчання і стратегічний розвиток. Планування запуску нових підрозділів, розробка індивідуальних навчальних програм для кожного закладу, формування планів розвитку закладів. І регіональна мережа та маршрути пацієнтів. Це проєктування маршрутів реабілітаційної допомоги, координація між стаціонарами, амбулаторною, первинною медичною допомогою і, відповідно, послугами на рівні громад. Підтримка регіональних управління мережею охорони здоров'я. Це 6 основних блоків, які включають цей компонент окремий. Зараз вже сформована команда понад 15 експертів, консультантів. Приблизно орієнтовно це 600 з гаком робочих днів і приблизно 8 місяців реалізації цього проєкту, або навіть цього компоненту в рамках цього великого проєкту. Що важливо і на чому я хочу зосередитись, це безумовно на тому, що для нас ближче, це один з компонентів, це безпосередньо аналіз витрат і фінансової стійкості, і чому він важливий, ми вважаємо і беремо його за основу, і сьогодні я дещо вам продемонструю. Самі наші експерти, які входять в нашу організацію, вони давно достатньо займаються аналізом витрат, фінансових розривів, економічної і фінансової діяльності закладів з клінічною складовою. Я пізніше покажу на пулі закладів, як це виглядає. Тому на цьому слайді ми можемо надати лише ключові такі аргументи, для чого це потрібно і чому це вважається важливим. Безумовно, це планування тарифної реформи або подальшої тарифної політики в реабілітації. Поточні тарифи НСЗУ ми можемо по-різному оцінювати, але зачасту вони не покривають, і у нас є певні дані аналізи, вартість пролікованих випадків, ну, особливо, якщо ми говоримо про реабілітацію. Аналітика закладає основу для подальших рекомендацій щодо оновлення пакетів медичних гарантій, зокрема з урахуванням складності пацієнтів, віку та типу реабілітації. Ну і кадровий потенціал, про що ми сьогодні говорили. І ось ці от, Ксенія, дякую, дані, вони багато про що говорять. Ми потребуватимемо, безумовно, кадрового потенціалу і ресурсу, але при зарплаті в районі $500-600 на місяць при такому завантаженні і збільшенні такого завантаження, ну, втримати медичний персонал або залучити його буде досить важко, попри те, як би ми це не пропагували і не говорили. Тому це окремий компонент, і він має враховуватись, в тому числі в тарифній політиці, і витрати мають бути ретельно розраховані на основі відповідних методик. Цифрові інструменти – це окремий блок, це використання електронних систем обліку витрат, костінгу, в тому числі Health Management Information System, тобто для управління саме фінансами для прийняття рішень закладів охорони здоров'я. Це велика прогалина зачасту, я це знаю, і навіть спілкуючись на заходах з керівниками наших центрів досконалості, я розумію, що розуміння деяких акцентів або показників, воно знаходиться на такому рівні, що потребує додаткового навчання і впровадження. Ну і, безумовно, ми переходимо до основного блоку – це навчання. Навчання ще раз, тому що ми оновлюємо заклади, встановлюємо обладнання, мільйони євро, але ми розуміємо, що і тарифи, мабуть, будемо вдосконалювати, але інвестувати треба в навчання персоналу, і це частина тієї спільної роботи, яку я хочу, щоб ми разом робили, і я про це говорив. Всесвітня організація охорони здоров'я підтримує навчання в центрах досконалості. Ми так само залучили в наш проект. У нас є керівники 2 центрів досконалості у вигляді консультантів. Це керівник ОХМАДІТу для дитячого реабілітаційного центру і, відповідно, центру ОХМАДІТу, центру досконалості, да, реабілітаційного відділення і, відповідно, центру досконалості у місті Вінниця. Ми маємо адаптувати навчання для тих закладів охорони здоров'я, але, безумовно, такі поняття, як вартість пролікованого випадку, реабілітаційного циклу в залежності від виду реабілітації, складності реабілітації, віку пацієнта, супутніх захворювань і так далі. Відповідно, вартість ліжкодня, коли я це задаю, ну, відповідь я не чую від керівників. Вони починають говорити, а нам заплатило НСЗУ. Ну, це не та відповідь, яка має бути від керівника такого підрозділу або такого закладу охорони здоров'я. Це такі показники, які варто вивчати, навчати, розраховувати, і вони мають бути зрозумілими для управлінців в тому числі. Це все передбачається. І тільки 2 виклики, з якими буквально дуже напружено останні 2 тижні, майже тиждень ми стикнулися. Перше, коли ми готували медичне завдання, є певні можливості у нашого міжнародного партнера, який бачить, у нього є фінанси, обмеження, технічні можливості і так далі. Але ми розуміємо, що присутність батьків при реабілітації дітей, це на 30-40% в показниках, це покращення ефективності самого лікувального процесу, особливо дітей до 5 років. Так само ми розуміємо, що це відповідає стандартам ВООЗ, ЮНІСЕФ, і на практиці означає подвійне інфраструктурне навантаження на заклад охорони здоров'я. Ми це вже прораховували, це харчування, спальне місце, гігієна, відповідно, навіть місця відпочинку, щоб вони мали побути і психологічно відновитися, поспілкуватися між собою. Це все має фінансуватися. Звідки? Ну, я розумію, що ніхто мені зараз не скаже, чи закладається це в тариф, наприклад, який сплачується Національною службою здоров'я України, дитячій реабілітації. Тобто ми, або заклад це має бути, а ми будемо планувати його стратегію розвитку, фінансову сталість і так далі, і ми будемо бачити ці розриви, які будуть. За рахунок чого це має відбуватися. Місцева влада, окей, ми посчитали, порахували, ми маємо сказати, будь ласка, місцева влада. Але досвід спихання на місцеву владу, ми знаємо, він завершується не дуже добре. Особливо, якщо ми говоримо, що це складова лікувального процесу. На 30-40% це складова. Друга частина – це окремі зони для нейрореабілітації та ортопедичної реабілітації і сенсорні кімнати. Почали моделювати, виходить так, що в одному приміщенні це неможливо. Ну, неправда. Ну, сенсорно окремо, да, а нейрореабілітація фізична. Тому, якщо у нас є обмеження в фінансуванні або в площах певних, ми виходимо на те, що йдемо на певний компроміс. Цей компроміс все одно призведе погіршення результатів реабілітаційного процесу. Тобто середні універсальні реабілітаційні інфраструктури неминуче створюють вузькі місця і знижують ефективність лікування. Тому це має бути враховано у пріоритеті фінансування також. Тобто збільшуються витрати в будь-якому разі закладу охорони здоров'я на всі ці речі. І, як стандарти ЄС і ВООЗ також передбачають адаптацію реабілітаційної структури під критерії, профіль пацієнта і так далі. Це я вам навів лише те, що от ми зараз в процесі медичного завдання почали узгоджувати, тому що є бажання і потреби закладу охорони здоров'я, є можливість міжнародних партнерів, є обмеження суми, об'єму фінансування, кількості площ, і виходить, чимось треба жертвувати або якусь частину відкладати на потім. Да? І навіть на цій стадії це вже певний виклик. Тобто все це потребує нового підходу до фінансування. І ми вже говорили про те, що зараз поки що ми сплачуємо за факт пролікованого випадку і ніяк не оцінюємо результат. І я так думаю, коли почнемо оцінювати якість реабілітації, це буде впливати на суму. Всі ці речі мають бути враховані. І якщо є відповідні умови для розміщення, в тому числі батьків з дітьми, то це має відображатися і на сумі оплати, і на тарифній політиці. Тепер буде інша цікава штука, дуже спробую швидко, але оскільки цифри мають бути сьогодні, то я їх покажу. Хочу сказати, що команда експертів працює в різних міжнародних проєктах достатньо давно. Якщо ви подивитесь, то це останні тільки проекти, квітень, листопад 2024 року, це аналіз витрат, фінансувався проект USAID, довготривалого лікування. Так само Emergency Department, оцінка витрат, cost accounting і аналіз пакетів прав медичних гарантій, що оплачуються за DRG. Це тільки за останній час. Я не можу, безумовно, вам в рамках цих проєктів повідомляти певні результати цього певного аналізу і так далі. Але ви бачите, що в 2012-2018 році був проєкт Health Finance і управління, in Governance, і тоді вже були започатковані і використовувалися ці міжнародні підходи. Була створена фактично за цей час досконалювалася ERP-система або Health Management Information System на певному підході і методики збору і обробки даних, що дозволяє за цей весь час в рамках національних проєктів, в рамках навіть індивідуальних запитів власників закладів охорони здоров'я, тобто місцевої влади, проводити аналіз лікарень. Вони всі зводяться в одну єдину велику базу, в якій зараз за різний період понад 600 закладів охорони здоров'я. І ці дані об'єднуються. Це не тільки зараз дані Національної служби здоров'я України, але і з медичних інформаційних систем, з медичної статистики, в рамках додатково зібраних даних і проведеного костингу і аналізу витрат в кожному закладі охорони здоров'я. Тобто ви уявляєте, там величезний масив даних, який можна вже аналізувати. Я вам покажу. Це кластерна лікарня, Київська область, дані взяті за 24 рік, аналіз проведений в березні цього року. Ви бачите вартість по відділеннях. Вартість витрат випадку по cost accounting лікування, бачите всі відділення, і вартість ліжкодня за cost accounting. Вибачте, вартість ліжкодня. Потім оплата за НСЗУ. Бачите зліва, перший, на жаль, не відображається. Вказівка. Оплата за відділеннями по відділеннях від НСЗУ. І фактичні витрати за cost accounting. Треба правильно читати ці дані. Ми рахуємо всі витрати всі витрати. Коли ми говоримо, що тарифи мають покривати всі, ми ж колись йдемо, що включимо і комунальні витрати. Да? Тому ми можемо виключати комунальні витрати. Але не розумієте, тобто це не факт того, що тарифи, от я вам зараз скажу, недостатні. Вони десь достатні, десь недостатні. Це факт в тому, що ми бачимо на графік справи і бачимо, що практично у всіх відділеннях стаціонару, крім неврології, заклад фінансування від НСЗУ не покриває витрати, які несе заклад охорони здоров'я. Бачите, по кожному відділенню, хірургія, акушерський і так далі. Якщо ми перейдемо далі, тобто неврологічне відділення з інсультним блоком. Як тільки інсультний блок – це пріоритетний пакет, да, він більше фінансується, ми маємо. Всі інші затягують заклад в мінусах. Якщо ми побачимо вже докладно, я розумію, що багато дрібних цифр, але ви зрозумієте, що це все з єдиної системи аналізується, причому з можливістю порівняння різних закладів охорони здоров'я. Ви бачите, оплата НСЗУ за договорами по пакетах. Ми зараз просто візьмемо окремі пакети і подивимося, який пакет в збитках, да, найбільших, а який найменший. Ми маємо оплату за договорами, маємо фактичні витрати і маємо по відділеннях профіти і збитки. Бачите нижню табличку, туди червоним це все от збитки, які йдуть. Відповідно, справи можемо фінансові розриви під час оплати НСЗУ за пакетами ПМГ. І ви бачите, червоний стовпчик безпосередньо, да? Це якраз програма медичної гарантії, це пакет 4, це терапія, про яку ми всі говоримо, да, які оплачуються. Ви бачите, що загальні збитки, НСЗУ покриває десь 75% витрат, дефіцит 25 мільйонів. Лише неврологія з інсультним блоком покриває витрати. І найбільший дефіцит лікування без хірургії – 31 мільйон. Тобто, коли б не інші, всі могли б заробляти, ви бачите, по пакетам є десь там плюс, мінус і так далі. Але цей пакет, він тягне заклад охорони здоров'я в мінуса одразу. Чому тягне? Теж це не тільки про тарифи справа. Да. Це розподіл пацієнтів з довготривалим перебуванням в кластерній лікарні. Ми пам'ятаємо, що ми концентруємо високоспеціалізовані послуги в кластерних лікарнях. А кого ж ми там лікуємо? Розподіл пацієнтів з довгостроковим перебуванням у стаціонарі з приводу серцево-судинних захворювань, да? З статевими віковими групами. А відповідно, внизу я просто одразу на помаранчеві можете подивитися, що 21% це довготривалих випадків, це пацієнти саме з такими хворобами. Вік відповідно зазначений. І 73,1 лікувалися у терапевтичному відділенні. Тому фактичні витрати на цих випадках 1,5 мільйона, НСЗУ оплатило 0,4 мільйона. Тобто фінансовий дефіцит за цими випадками довготривалого лікування 1,1 мільйон гривень. Те, що йде в цьому стаціонарі. Це одразу у нас посил до роботи первинного надання медичної допомоги, яка має попереджати. І друге – це доступність тривалого догляду, лікування, сестринського догляду ближче до місця проживання населення. Цих людей, в принципі, в кластерній лікарні не мало б бути. Коли вони туди потрапляють, ми бачимо пакет фінансування, а витрати в кластерній лікарні одного ліжкодня, враховуючи персонал, обладнання і так далі, якщо пораховані, вони набагато вищі, ніж загальні лікарні. Тому такі нескладні випадки завжди будуть тягнути заклад охорони здоров'я вниз. Тому, по ідеї, вони б мали б не госпіталізувати, але виходу іншого немає, вони ж не можуть відмовити. З іншого боку, ми знаємо, що відбувається з малими лікарнями в сільській місцевості. Що, ви бачили ці всі речі. Тобто, якщо цей процес не керований і ми не робимо з цими лікарнями чомусь, вони завантажують кластерні лікарні такими випадками і тягнуть їх вниз через це все. І ви ж, мабуть, хочете подивитися щось по реабілітації. Це дуже швидкий аналіз попередній. На даних 23-го року, просто мої експерти попросив, вони вивели. Значить, це з цієї системи ERP FinHealth, значить, 7243 випадки. 16 закладів охорони здоров'я, в яких є реабілітаційні відділення, 9 регіонів, і, відповідно, це пакет 53, стаціонарна реабілітація. Значить, перший слайд – це тенденції надання реабілітаційної допомоги дітям. Це в цей пул потрапило три дитячі реабілітаційні відділення, кількість випадків 507 і 3 регіони. Ну, ми вже бачимо домінування опорно-рухової реабілітації. Із них 32,3% – це випадки складності реабілітації 2, тобто це висока складність. Вказує на велику потребу фізичної терапії, адаптації до активності і вертикалізації. Неврологічна реабілітація 42%. Рівномірний розподіл по складності є практично по всіх. І висока складність 18,7%. Найпоширеніша група дитячих реабілітаційних відхилень, ДЦП, порушення розвитку, затримки моторики і так далі. Значна частка кардіореспіраторної реабілітації 19%. Ці вимагають інтенсивного догляду частіше після тяжких інфекцій, пневмонії, вроджених патологій. Тобто 80% випадків реабілітації дітей – це неврологічна реабілітація та опорно-рухового апарату і 77,5% з високою реабілітаційною складністю реабілітаційних втручань. Розподіл вирішили подивитися все ж таки місто і обласний заклад, і заклад міський. Да? Тут прямих висновків немає. Це треба вивчати, да, чому так стається. Да, як концентруються всіх, ну, можна сказати, що кластерних і надкластерних заходів. Ну, не завжди так, але в принципі так. Ми маємо, що 5785 дорослих пацієнтів, 10 ЗОЗ в цьому пулі вибору, да, і 7 регіонів. Найвищий рівень складності домінує в обох закладах. Це 55,5% в обласних, 45,9% у міських. Це може свідчити про високу концентрацію тяжких випадків або недосконале розмежування за складністю у процесі надання допомоги. А високий рівень складності, да, СР1, частіше зустрічається в міських закладах, 29%, проти 15,5% в обласних. Можливо, це відображає інший профіль пацієнта або особливості класифікації, але ми ще можемо говорити про особливості обліку, да, і ведення електронних медичних записів. Середній та низький рівень складності 15,1 в області, 5,4, тобто він значно меншу суму складає. Це може свідчити про недостатність спрямування пацієнтів з легкими травмами, про що ми говоримо, реабілітація на рівні громад, на рівні амбулаторному рівні і так далі. Вони потрапляють в стаціонар, де вони могли б і не з'являтися в принципі. І невизначений рівень складності взагалі становить 8,2 і 10,4% в міських, що вказує на проблеми з веденням обліку документації та ускладнює повноцінний аналіз. 10% достатньо давати для аналізу. І два останніх слайди. Це Київська обласна клінічна лікарня. Просто взяли її одну. Да, формує рівень складності 1, формує 61% у всіх випадків, але є найбільш збитково саме в цьому закладі охорони здоров'я. Тобто перший і другий рівень мають найвищий рівень покриття, менше 50% при високій собівартості. Можна аналізувати додаткові витрати, чому в них так. Да, тобто, можливо, неефективність витрати завищені вони, а можливо, вони якраз притягують на себе найскладніші випадки, які потребують більших витрат і не покриваються навіть тими тарифами, які є. Хочу зауважити ремарку зробити, все ж таки ми взяли 23-й рік. Зараз тарифні коефіцієнти, ми будемо дивитися, аналізувати, як це може змінюватися далі. І останній слайд – це взагалі аналіз фінансового покриття витрат у реабілітації за напрямками і рівнями складності і загальні висновки. Тобто я вам привів заклад обласний, да? Але там взагалі усі види реабілітації по складності 1 покривають витрати щонайменше на 70%, деякі на 100%. Ну, хочу сказати, що ми, в принципі, при аналізі можемо провалюватися в кожен пролікований випадок і дивитися збитки по кожному пролікованому випадку або прибутку, що свідчить про відносну адекватність тарифу і найменшому рівні складності, і найвищому рівні складності. Другий, третій спостерігається висока варіативність покриття від 70 до 94%, що вказує на ризик недофінансування окремих напрямків, особливо неврологічної реабілітації. І потенційні проблеми. Знову ж таки, це такий перший погляд. От ми зараз, якщо сконцентруємося на реабілітації в роботі в тих закладах охорони здоров'я аналізу, будуть більш конкретні цифри і більш перевірені з певними, можливо, висновки. Неврологічна реабілітація, нетравматичні стани має найнижчі показники покриття. 70 і 77,6% це може свідчити про недооцінку трудомісткості послуг. Це ми говоримо про оплату персоналу, да, про складність їх роботи і так далі. Потреба оновлення підходів до тарифікації, підвищення фінансового навантаження на заклади, які спеціалізуються на цих випадках. І кардіореспіраторна реабілітація має понад 100% покриття, що може бути пов'язано з недооцінкою реальних витрат іншими закладами, у разі неформального недообліку ресурсоємності. Ну, я офіційною мовою про це кажу, але в принципі ви розумієте, що варіацій трактувати ці дані багато, і попереду у нас велика робота для того, щоб реабілітація була ефективною, фінансово стійкою. В принципі, ми будемо працювати, система у нас є, будемо працювати на цих закладах, будемо зустрічатися, я буду розказувати про міжні варіанти, які у нас є, бо ми будемо проводити костинг на цих закладах і на дитячій реабілітації, що важливо. І якщо наші партнери, Health Cluster, хочуть масштабувати це дослідження, наприклад, це можна зробити досить швидко з допомогою тих інструментів, які у нас вже є, і досвіду, який є в міжнародних проєктах, які вже були, і навіть національних пілотних проєктах про розрахункові практики. Дякую, друзі.
Дуже дякуємо. Okay, dear colleagues, thank you for getting loaded with numbers and statistics, so many interesting facts. Now I'm happy to announce that we will have a lunch break. And I suggest us to have 30 more minutes.
One more
Can we have it after the lunch, please? Because it's hot and it's getting cold online.
But some colleagues are waiting online, texting that they are not able to join after the lunch. If it's possible.
Oh, no problem. Sure. Then we are moving forward.
Yeah. Thank you, colleagues.
Okay, I'm sharing the slides. They are here.
Ми багато говорили сьогодні про стаціонарні послуги, але задаємо піраміду надання послуг, і концентрація важких випадків, які потребують реабілітації в стаціонарних умовах, це менша частина потреб, які є по реабілітації. Нижня частина – це все ж таки те, що набагато нижче, і це рівень громади. І коли ми аналізуємо дані лікарень за 23-й рік, ми розуміємо, що у нас там вже багато чого напрацьовано. А що відбувається на рівні громад, там, де найбільша потреба в реабілітації, то ми зараз трошечки представимо цей наш підхід, який був в проєкті Rehab for You розроблений. Ми проаналізували потреби людей на рівні 10 громад. Наступний слайд, чи можна, або клікер, чи є?
Як вам зручніше? Євгена позичення клікера.
Так, не буду зупинятися на самої. Розкажу трошечки про ці 10 громад. Ви бачите, вони в різних регіонах. Ми брали спеціально такі обирали громади, які не мають кластерних лікарень. Тільки загальні лікарні, відповідно, це створює певну проблему для місцевих жителів, для того, щоб отримати реабілітаційні послуги. Також ви бачите громади від 13,5 тисяч, Близнюківська, Харківська область, до Овруцькій громаді 34 тисячі. Тобто це умовно там, де проживає 60% населення України. І тут ще один момент є, що, от, наприклад, Близнюківська громада 13 тисяч має 96 сіл. Тобто це дуже розпорошене проживання населення. І, звісно, щоб добратися і отримати якісь послуги там, де вони є, фахівці, це дуже велика проблема. Те саме в Овручі, 90 чимось населених пунктів. І, це, звісно, виключення. Середня кількість населених пунктів близько 30 в кожній з цих 10 громад. І ми також обирали ці громади для того, щоб отримати більш мотивовані громади, які згодні ділитися даними, приймати до себе візити і так далі. Загальна ситуація по громадах, вона досить така середня, як для України. Від 5 до 10% це люди з інвалідністю в цих громадах проживають. Від 16 до 24% люди старше 65 років. Також більш-менш цифри середні по Україні. Кількість вимушеного переселення, звісно, залежить від розташування регіонального від 20 до 30%. І бачите, що 45 або 100% це сільське населення. І нижче ви бачите в правому куточку тут, як представлені надавачі послуг, які формально існують в системі. Тобто серед цих 10 громад 4 тільки мають, вони всі мають загальні лікарні, всі ці 10 громад. але тільки 4 мають пакет НСЗУ на стаціонарну допомогу, і 5 з них мають пакети на амбулаторну допомогу. Наш підхід базувався на 3 ключових речах. От сьогодні колеги з ВООЗу говорили, що в їхньому розрахунку кадрового потенціалу перше – це розвивати потреби населення в реабілітаційних послуг. Ми використали з лівої сторони, використали дані НСЗУ для цих 10 громад, звернення пацієнтів в систему по 27 захворюваннях, які визначені Всесвітньою організацією охорони здоров'я, які потребують реабілітації. Вони згруповані в 8 груп. Там по QR-кодам, ви цю презентацію отримаєте, по QR-кодам можна подивитись буде на ці підходи. З 2019 року, ви знаєте, це глобальне дослідження Всесвітньої організації охорони подовжено в потреби в реабілітаційних послугах. І там є дуже цікавий інструмент, от нижнє там посилання, де можна подивитися Україну в тому числі, але це так на глобальному рівні. Ми використали такий самий інструмент для того, щоб подивитися на рівні цих 10 громад. Другий компонент дослідження будувався на глибинних інтерв'ю, виїзди в громади, глибинних інтерв'ю ключових зацікавлених сторін. Третій – це ми вже порівнювали і одні інші дані для того, щоб зрозуміти, які загальні тенденції існують. Ну, в цілому, якщо подивитись, то 20% населення щорічно потребують, ми брали дані за 24 рік, тобто всі ці захворювання, які були в 24 році. За самими такими скромними підрахунками, 20% населення, тобто це фактично людей, хоча ми розуміємо, що потреб у людей може бути більше. Тобто одна та сама людина може мати кілька захворювань, які потребують відповідно реабілітаційних втручань. Але кожен 5-й, і якщо брати 65+, то це кожен 4-й. Ці громади тут також представлені, і от справа показані середні розрахунки на 10 тисяч населення. Щоб ми бачимо, що фактично для цих громад цифри приблизно, середня цифра 2 тисячі населення на 10 тисяч, от ці самі 20%. Обмеження, які існують такого підходу. Те, що ми бачимо тільки тих людей, які потрапили в систему, ті, які мають діагноз або зверталися за медичною допомогою. Звісно, ми можемо ці цифри збільшувати, розуміючи, що не всі люди зверталися за медичною допомогою. Особливо люди, які мають біль в спині. Якщо це людина періодично буває, вона може і не звертатися за медичною допомогою, вона в цю статистику не потрапляє, але якщо б були послуги реабілітації, вона б їх могла отримати. І так само це включає тільки ті заклади, які мають контракт з НСЗУ і відповідно ведуть відповідний облік. Це такі основні, можливо, проблеми з кодифікацією існують, але, умовно, це мінімум, на який можна орієнтовуватися. Це структура, про яку вже говорили, вона дуже схожа про те, що взагалі існує. Якщо порівняти з тим інструментом, який використовував ВООЗ, у нас є певні диспропорції. Тільки тому, що ми не фіксуємо багато з цих захворювань в нашій системі охорони здоров'я. Наприклад, сенсорних у нас менше, ніж в ВООЗівських оцінках, або, наприклад, більше кардіоваскулярних захворювань. Тобто є певні диспропорції, але розуміння того, що 50-60% – це опорно-руховий апарат, це зрозумілий підхід, і ми на цьому також потім трошечки зосередимося. Що стосується асистивних технологій, ми бачимо, що в всіх громадах більш-менш є доступ до цих технологій. Зазвичай вони, якщо подивитись, зліва це найбільш затребування, які виникають асистивні технології, справа це де люди можуть отримати їх. Звісно, це 4, про які я сказав вже, пакети стаціонарної допомоги, і ці лікарні мають кабінети асистивних технологій. В 10 громадах працює служба замовлення. Тобто можна замовити або безпосередньо через фонд, або можна через онлайн запит це зробити. І так само в 10 громадах є пункти тимчасового прокату цих засобів. Вони в основному наповнюються за рахунок благодійних коштів, але дуже швидко розходяться ці інструменти, але доступ до них є. Ще важливий, тут показані взагалі, які існують структури в цих громадах. Як я вже сказав, є лікарні, хоча не всі мають ці пакети, є центри первинної медичної допомоги, є територіальні центри соціальної допомоги, і головний проблема в цих всіх структурах, що вони між собою не координуються. Тобто мають дуже слабку координацію, немає кейс-менеджменту і багато інших речей. Тобто певні структури є, певні фахівці є, але вони поки що мало залучені до системного надання реабілітаційних послуг. Особливо це стосується центру первинної медичної допомоги. І коли ми говоримо про фахівців, коли робимо оцінку, ми говоримо дуже часто про те, що фахівців з реабілітації. І в нашому законі там немає фахівців первинної медичної допомоги, що дуже дивно. Ми про це ще поговоримо далі. Які виклики існують? Фінансові і інфраструктурні бар'єри, як я вже сказав, дуже велика розпорошеність і те, що людям треба долати велику відстань, щоб потрапити там, де є фахівець з реабілітації. В той час, як поряд може бути амбулаторія загальної практики, тобто місце надання послуг може бути, але вони не надають таких послуг. Також нестача людського капіталу, і це мова йде не тільки про фахівців з реабілітації, а також про інші ті структурні елементи, які залучені до надання цих послуг. Ну і також не існує достатньо механізмів взаємодії між цими структурними підрозділами. Що стосується можливості, то як я вже сказав, у нас і громади відбирались на основі їх проактивності. Таким чином, готовність цих громад розвивати цей напрямок, він достатньо високий, ці можливості можна використати. Ну і стосовно висновків. Які висновки? Як я вже сказав, що 20% жителів цих громад щорічно потребують послуг реабілітації, як мінімум, і 65+. Тобто ці дані, я не скажу, що вони репрезентативні, але їх точно можна використовувати для грубих оцінок. Беремо будь-яку громаду, беремо Україну в цілому, область, можна сміливо ці цифри використовувати, бо якщо ми візьмемо інструмент ВООЗ, там цифри будуть в 2 рази вищі. Але це на реальних цифрах, які в нас вже є, що люди є в системі, ми їх бачимо, і ці люди мають такі потреби. Про структуру ми вже сказали. В усіх цих громадах попит на ці послуги, він набагато вищий, ніж можливість його задовільнити. У всіх громадах суттєвий дефіцит професіоналів в сфері реабілітації, дуже слабка залученість первинної медичної допомоги до надання цих послуг, хоча практично у всіх клінічних настановах первинної медичної допомоги реабілітація є окремим рядком. Візьмемо найбільш поширені стани артрози чи біль в нижній частині спини, всюди є прості речі, які може робити первинна медична допомога. Але поки не робить, тому що немає ні стимулів, ні навчання, і взагалі цих діагнозів у нас немає. Якщо ви порівняєте кількість діагнозів біль в нижній частині спини нашої країни і будь-якої розвиненої, ми побачимо кратне відставання, бо первинка навіть цим не займається. Далі, в Україні відсутня така професія, як фізіотерапевт першого контакту або прямого доступу. Це те, що дуже підтримує первинну медичну допомогу в розвинених країнах. Візьмемо там Нідерланди або Великобританію. 1/10 фізичних терапевтів, які працюють в системі, в Великій Британії це фізіотерапевти першого контакту, які дуже суттєво розвантажують первинну медичну допомогу і, відповідно, більш спеціалізовані рівні. Інфраструктурні бар'єри, ми тут казали, і географічна великі проблеми з географічною доступністю. І які рекомендації на основі цього звіту? По-перше, продовжувати розвивати існуючу інфраструктуру. Ми побачили, що багато структурних елементів є, але вони поки що між собою не дуже узгоджені в спільному баченні, як вони мають працювати. І це відсутність саме концепції або візії, або, правильними словами, моделі надання допомоги на рівні громад. І, звісно, як і будь-які послуги на рівні громад, якщо ми візьмемо паліатив або довготривалий догляд, всі ці послуги, вони мають певну свою природню особливість, що ці послуги, вони не можуть бути дуже чітко стандартизовані в посадах, робочому часі, там, навантаженні і так далі. Бо сама природа послуг на рівні громад полягає в тому, що вони мають адаптовані бути до місцевих умов. І навіть в одній і тій самій країні вони будуть розрізнятися. Загальний підхід є, ролі прописані, але як це реалізується на кожній громаді, може суттєво відрізнятися. І далі ми говоримо про те, що необхідно посилювати людський потенціал на рівні громад. вкладатися в залучення цих фахівців. Про це сьогодні також вже говорили. Покращувати географічну доступність шляхом створення відповідних транспортних можливостей і або навпаки мобільних надання послуг. Це також треба розраховувати на рівні кожної громади. Ну і підвищення обізнаності населення, що такі послуги є, вони доступні. І тоді частина людей, які раніше не зверталися по цю допомогу, можуть звертатися, якщо ми створимо відповідних надавачів цих громад. Підтримка громадських ініціатив, і також дуже важливо, ми мало займаємося взагалі нижнім рівнем піраміди. Да, згадайте її, це самодопомога, самоменеджмент при таких станах. Якщо ми відкриємо, наприклад, NHS сайт британський, там всюди є рекомендації для пацієнтів, є відео, які вправи корисні і так далі. А у нас зараз пацієнт з певними станами отримує навпаки рекомендації від медичної спільноти про те, що там обмежити рухливість. В той час, як навпаки, треба робити вправи. І замість того, щоб скорочувати реабілітацію, ми її навпаки продовжуємо. Коли людина наприклад, з артрозами або з білою в нижній частині спини, вона обмежена в своїй функціональності. Ну і відповідно такі базові оцінки треба робити, і потім вже дивитись, робити пілотні проекти і дивитись, як буде розвиватися цей напрямок і які моделі можна буде потім пропонувати для національного рівня і оплати зі сторони як Національної служби здоров'я, так і місцевими громадами, оскільки послуги на рівні громад зазвичай мають кілька джерел свого фінансування в світовій практиці. Дякую за увагу.
Thank you. We've had a beautiful phase of the info presentations. Thank you so much. So we are proceeding now for 30 minutes lunch break, and at 2 we will be back for a round of discussions, networking, and prioritization of the investments required. Thank you, and we'll see you in 30 minutes. Before can you open the door? Okay, kind of, but all of us are back and we can start. The second part after lunch will be more relaxed. And also, we are very welcome to share your updates in case you would love to do so. Maybe you have some interested projects that you are planning to implement, or you have current ongoing activities that you would like to share. We will be more than happy for you. We can start with us. We can start with anybody who wants. I don't think we will go in a circle, not to put some pressure. But yes. Pablo, can you start from your side? It's not a lot of updates. I think now it's a busy time for other activities also.
It's not a lot of updates. From WHO side, WHO will continue to coordinate multidisciplinary rehabilitation trainings as usual in 3 centers of excellence. Also, I want to mention that in August, a training for trainers according wheelchair will be conducted for 10 participants who has already conducted basic level and intermediate level. Also, training basic level wheelchairs will be conducted in August for 80 participants. It was at the same time in Kleven, Rivne Oblast, and in Dnipro. So if you have or would like to add some specialists, it concerns physical therapists or occupational therapists. If you want to add, please connect with me or Ksenia, and we will add the persons to the trainings.
Yeah, as last year, we were dedicating 20 spots for our operational partners out of 80. So if you would like to add not more than 3 colleagues from a partner, we will be happy to support. However, we are supporting with certification and the training and training materials itself. And your organization will be supposed to cover accommodation because we don't justify it further. So yeah, during the next couple of weeks, we have all 20 spots available. Please contact us and we will be happy to get your colleagues. Somebody else would like to share an updates if there are some just general on the areas covered and activities provided.
Yes, I am Svetlana. Once again, just for those who we forgot. So actually, we are currently the project in Iván-Kivska Gromada is ongoing now. I already reported for on the previous meeting. So actually, what is a capacity building intervention? What does it mean? It's one of the several intervention. One of them is this is reconstruction of the health facility outpatient part, Iván-Kivska Central Hospital, yeah, physical rehabilitation. So actually we are working on it. Second part, this is a capacity building component. We are now going and working with it identifies the IP for conducting this as part of the project. It will be as well donation of the equipment to this health facility, and a very important component for us, this is as community-based intervention. Disability inclusion component as well was included, and from our organization, Health, our department is our project, and it is Shelter who will be doing this reconstruction, and MHPSS component and disability inclusion as well included. So it will be some focus group they will be conducting, communicated with the Gromada, and to absorb the access and to remove the architectural barriers for people, not only maybe for health facility and for some education and social structure. And then we are as well close, like I said, it's multi-sectoral approach, and We contacted social center, territorial social center, and we will donate for them one vehicle for transportation of people with disability. So actually, it's like it will be a health promotion the session, and we will use your leaflets. You share it. Yes, we will print, and this will be like spread among the, because thank you, very good information there. So this is like regarding the physical rehabilitation component, and we're doing a lot of other activities, but this is meeting. This is one important thing. Yeah, thank you.
Thank you so much. If you need printed leaflets, now so we have a pile of them behind our backs in the office. If you would like to request,
thank you.
Thank you. Somebody else would like to share short updates regarding rehab?
Maybe I will share. So in terms of general momentum activities, we are right now just finished training of Galician Center, physical therapists and occupational therapists on mobilization. So the event happened in our AT hub, and our mobile team worked with the trainees. And we are planning to conduct the similar training for social worker and for hub of habilitation, which are working nearby our AT hub in Lviv. That's all activity happening in terms of support of Christian Blind Mission. In addition, we are conducting provision of assistive technology to the beneficiaries, direct provision. So we are doing this work both ways through healthcare facility we are partnering with, and through like directly to the beneficiaries. That's happened through our mobile team as well. So it's include all the steps, all the 4 WHO steps of provision. In terms of new activities, we just started the project funded by Direct Relief International. So this will be infrastructural project. In terms of this project, we will work in Chernihiv and Chernihiv region. We will identify 6 healthcare facilities. Next week, we will start the site visits. We are planning to facilitate refurbishment of this healthcare facility with the goal to establish outpatient departments, and in future to receive like possibility to provide outpatient support through NHSU packages. In addition, we will do trainings for this healthcare facility for their specialists, and of course, we will provide all needed equipment according to an HSU list of equipment. If to say about the Hub for You project activity, I will not spend a lot of time because a lot ongoing from the significant things. We just finalized assessment, which we present right now, and we'll move further in development of the model. In addition, we are finalizing assessment in terms of assistive technology cabinets working, operationing. So that will be as well publicly available, I will hope, later on. And we are planning to conduct 1 week workshop in terms of SCI. 4 international experts will come. That's workshop will be for the multidisciplinary team of 5 centers of excellence and will be conducted in July in Rivne hospital. Plus, we are preparing to the TOT for ergotherapists. That will be academical course. That's course will be for 5 universities. 25 ergotherapists from 5 universities will pass on the 2 weeks online TOT and 2 week offline TOT. So from the general update, I think that's pretty all for this moment.
Thank you. Yes. Chernihiv, you already identified the hospital?
We're in the process. We will conduct the site visit. So now it's a great time to coordinate and to see not to have overlapping.
Because we work with the Chernihiv hospital last.
No, yes.
So just
we already discussed
we can coordinate.
Okay. We coordinate for sure because of course the needs is huge, so no sense to overlap that.
Or maybe we are supporting on something.
To complement each other.
Reconstructions. But anyway.
We as well do not doing reconstruction, only refurbishment. So it's like much more. We are saying no with refurbishment.
Sorry. And the TOT is about
spinal cord injury. So that will be related to spinal cord injury. That will be the preparation, like that will be workshop in preparation to TOT. That will be not exactly TOT itself. That will be preparation phase to work with the teams, to see the needs, to see what will be needed to be included into the course. And the next year we will conduct 2 or 3 weeks TOT. We will see what will be the duration.
Okay, thank you. Thank you. Okay, let's kind of continue our Chernihiv theme, because you probably know that kind of Annabelle has 2 focal regions. Kind of one is Chernihiv Oblast, another one is Kiev Oblast, and kind of our colleagues decided to include Kiev City also in Kiev Oblast, although there's kind of 2 different territorial kind of units. So now, kind of from the beginning of the year, we started reconstruction of 2 cluster hospitals in Chernihiv Oblast, in Kharkiv and Prilupki. And in parallel, the multidisciplinary teams from the hospitals are now taking kind of specific training, of which kind of Yana will inform in the Center of Excellence in Ivano-Frankivsk Oblast. In addition to Kharkiv and Prilupki in Chernihiv, we also have reconstruction helped in 2 hospitals in Kiev Oblast, one in Kiev Regional Hospital, and also in Kiev City Hospital number 8. And they also participate in this kind of multidisciplinary teams kind of training in Ivano-Frankivsk. And we also probably will take Bila Tsarakva and City Hospital number 2 with kind of reconstruction. And they are now at the stage of developing kind of the design documentation. So we're moving to the next stage. In addition to this, kind of there's a whole kind of training component to it. What kind of our partners in this are Ukrainian organizations, Ukrainian Association of Physical Therapists, and Protest Hub, together with Patients of Ukraine, and Ukrainian Association of Speech and Language Therapists. And together with them, we started the TOT for kind of speech and language therapy, potentially for kind of developing the master course for them. We're trying to engage our kind of Belgium University colleagues if it's kind of hopefully that will be more than just one kind of participant that we currently have. In addition to this, kind of Patients of Ukraine are now kind of in the assessment process of what is possible, what is kind of provided in rehabilitation services, both in Kiev Oblast and in Chernihiv Oblast, just to look and prioritize the healthcare facilities with which they will develop patient pathways up to the follow-up to the local level, to the community level, rehabilitation services, very similar to what was presented today by our colleagues from Rehab for You. They're still in the assessment process, but we are kind of looking at probably the same places like Maria, you were telling, in terms of kids. And we'll see what we can do with them, and whether we can have some disability inclusion things for them, is a kind of depending what they need to do, whether they have plans for kind of this barrier-free plans in their communities. So we just really to very closely collaborate with all the partners who are working in the same areas. And I'm giving to Yana to talk about the training component.
Yeah, thank you. Following the policy of the MOH and the vision how to the multidisciplinary team should be trained, we use as a platform for the training purposes Ivano-Frankivsk Center of Excellence. We are sending them to them for the four months training hybrid mode 5 hospitals, 2 from the Чернігів, Прилук and Kurykivka, and 3 from Kyiv and Kyiv region. It will be the first phase. And the second phase, it's our intention to support a center of excellence in order to scale up their knowledge. In the first part, we donate them the new technology for the piloted innovation, as it's one of the pillar of the enable nature. We donate smart insults technology for them to try to see how these new technologies can help them. It's technology who aim to support multidisciplinary team in order to find out the problems with the gate and to make some corrections in this way. And the next phase, we are looking for some additional trainings inside the country and outside for those specialists who are working in the Center of Excellence in order to provide them as well support. And besides of that, we are in order to finalize the list of equipment and medical furniture for the hospitals where we are doing reconstructions to equip them fully as they need according to the NHSU requirements.
I have a question, sorry, the training is on what?
It's on the 20 topics according to the questionnaires that they filled, the 5 hospitals before they went to the Center of Excellence. The team of Center of Excellence create the curriculum for the 4 months according to the topics and the gaps to the topics. Yes, we can share.
Yeah.
It will be great to see.
Yeah. And you were talking about speech and language therapy master course. So you're developing the master course right now.
Well, this is the intention of the Ukrainian Association of Speech and Language Therapists. We are helping them. We cannot say that we can cover all the specialization, all the specifics of the course, but we are now helping them just to do the TOT.
Okay.
And after the TOT, it will be we are working on the master's. Some of the courses we will help to develop with hopefully engaging a number of one Belgian university, but it's a job for more than just we are not going just to cover the whole master program, but we understand that this is the kind of big priority for the professional association. This is also a big priority for the Ministry of Health. Say we are contributing to this. Another topic that I didn't mention is we are thinking or developing specialization on wound care management for nursing, and we are currently in the formulation process stage and discussing who can be our partners on Ukrainian side, which are medical schools or nursing schools, and probably look at the nursing curriculum to introduce this topic into nurse education.
So can I? Yep. My name is Maria, and I'm presenting the Ukrainian Norwegian project, and we are really interested in collaborating in nursing because it's one of our high priority. Right now, we have 4 main domains. It's the adults neuro rehabilitation, it's pediatric rehabilitation, nursing, and a little bit aside is the adaptive sport. It was built from the pediatric rehabilitation after the kids finish the rehabilitation. So now we are gonna focus on the nursing, and we have actually collaboration with the focus on obviously centers of excellence, and we're collaborating with probably 5 centers of excellence, also 4 adults and 1 pediatric, Ahmadit, and also we have a couple of partners hospitals. Bila Tserkva also is our partner hospital, Bila Tserkva City Hospital number 2, and the Lviv Territorial Union. So I will be happy to share our activity plan and ideas in nursing.
Can I go? I'm sorry, I have a train, so I will have to leave in a couple of minutes. From humanity and inclusion side, we continue both capacity building activity and direct implementation of rehab services at community level. For capacity building, we have to reduce our activity, so we'll focus now only in Kharkiv Oblast. So we already stopped in Mykolaiv last month, and we will stop next week in Dnipro. For community-delivered rehabilitation, we continue in the 3 oblast. We have 8 PTs covering the 3 oblast, and mainly it's home care visit because most of the patient cannot reach the primary health care center. Our first plan was to provide more consultation at PHCC level, but months after months, we can see that a lot of patients cannot reach the PHCC, so we provide more at-home visits.
They cannot reach? Just on top of your head.
There is no specialized transportation, or it's expensive. They don't have enough money. It's far away. There is no one to bring them. Yeah. So basically, this is cost effectiveness. So this is why, and there is now so many humanitarian support for specialized transportation. Some NGO plan to, but with the cut of funding, it's part of the project that was not able to start, especially in Kharkiv. So yeah, we were hoping to have like a collaboration between 2 NGO, us and it was PUI, and to say, okay, we have the patient, you have the transportation, let's go to PHCC. But no project, no, less PHCC. We hope that we will be able to do it, but that's true, this is a real issue to reach the PHCC for patients.
It's reflexive, okay? Question.
Senya is the boss.
You're a boss.
Open space.
Okay. Я українською, я попрошу тебе. Власне, в мене просто уточнення. Я хотіла, ми дуже швидили перед ланчем і були цікаві доповіді. В мене виникло кілька питань, деякі вже з них розвіялися, але одне лишилося. Власне, до пана Євгена, чи правильно я зрозуміла, що ви допомагаєте розбудовувати реабілітацію в місті Ладижин Вінницької області?
Один заклад, так.
Один із закладів.
Аналізуємо, але співпрацюємо з регіональним департаментом. Відповідно, будемо збирати інформацію про реабілітаційні маршрути. Ну, і ми розуміємо, що це 2 додаткових заклади з додатковими послугами, вони мають стати частиною мережі реабілітаційної допомоги.
І це, власне, наскільки я зрозуміла, це санаторій, і це 46 ліжок.
Пенсійно, так.
Мене просто...
Вибачте, ще раз скажу. Це Ладижинська міська лікарня. Поряд з нею, точніше в Ладижині, був санаторій, який належав ДТЕКу. ДТЕКу меморандумом передав цей санаторій, профілакторій міській лікарні. Міська лікарня зробила проєкт, точніше міська влада зробила проєкт і залучила фінансування.
Я просто хочу кілька слів реально про ризики. I want several words about risks in some activity. Okay.
Переклад. I just think that it's a bit late, so I don't know.
Ukrainian. Я просто хотіла про деякі ризики в таких варіантах, бо коли ми говоримо про стратегію Міністерства охорони здоров'я, то стратегія все ж таки на кластерні, надкластерні лікарні. І мені зрозуміло, чому, наприклад, колеги з одного проєкту сказали, що ми надкластерним допомагаємо кластерним, колеги з іншого проєкту чітко сказали, що лікарні звичайні, де немає в громадах, і це якось зрозуміло. Але от якщо пов'язати доповідь Ксенії, звернутися трошки кілька кроків назад, що у нас є проблема шалена з тим, що обманюють з дипломами, чесно, підкладають. У нас є проблема з кількістю фахівців, власне, і з тим, що в нас нестаціонарні пацієнти знаходяться в стаціонарах. І про це всі говорять, що люди не завжди потребують стаціонарної допомоги, але закладу дуже вигідно отримати ті пакети. Про це багато говориться.
Вибачте, будь ласка.
І, власне, я просто відкриваю карту і дивлюсь, що це містечко має 2500 жителів.
Ні. Ну, я ваше питання дуже розумію.
Я просто до того, що яка потреба безпосередньо цієї громади мати 45 ліжок стаціонару. Якщо я знаю, наприклад, що Івано-Франківський центр досконалості має 33 ліжка і більше 40 фахівців, які забезпечують... Тетяна.
Ну, ви почули мій невеликий акцент, коли я про це говорю, так?
Да.
Я думаю, що ви...
Просто про вибір закладу.
Да, я зараз поясню, що я не задавав це питання на етапі чого, то я, звісно, його задавав.
Мене це питання мучить.
Да, тому, якщо вже ви запитали, я його задавав. Але, повертаючись, рішення міністерством прийнято, міжурядова угода підписана. Да, ми маємо якби його виконати. Я даю відповіді, чому так стається, тому що у нас є гайсинг. Це, здається, 40 кілометрів, і це кластерна лікарня, в яку теж інвестуються гроші для розвитку реабілітаційного відділу. Але, тим не менш, наприклад, голова регіонального департаменту, він приїжджає, відкриває і встановлює обладнання в Гайсені, потім, значить, їде, спілкується і розбудовують, і планують, і інвестують гроші в Ладижині, значить, в цей заклад. Питання оцінки потреб, про що ми говоримо, і що важливо в довгостроковій перспективі, коли ми говоримо про стратегію, що буде з цим закладом через 5 років, так? Якщо буде продовжуватися, розвиватися кластерна лікарня, хоча вона зараз слабка, вона слабкіша, ніж цей загальний заклад, з точки зору потенціалу, розвитку і всього остального, і медичного персоналу. У нас децентралізація, друзі. Ми дуже свято віримо в спроможну мережу, як щось непохитне і стале. Воно так не є, тому що я був аналітиком в проєкті USAID моделювання госпітальних округів. Тому те, що було прийнято, воно, в принципі, в деяких випадках не наладить на те, що моделювалося. Точно так же, з точки зору політичної кон'юнктури, коли приймалося рішення. Далеко не всі заклади, які були прийняті кластерними, вони відповідають тому, що вони є кластерними. Так само, як далеко не всі, що стали загальними, вони не хотіли бути і вже не були навіть загальними. У них навіть хірургії вже не було, а вони були визначені загальними. Тому в даному випадку, з точки зору розташування, районний центр визначений Гайсен, з точки зору потенціалу розвитку і грошей місцевої влади. Тому що в Ладижині бюджет більший, ніж майже у Вінниці. Там ТЕЦ і все інше. Тому місцева влада хоче, вони розробили проєкт, заплатили гроші за його розробку, виїхали до міжнародних партнерів, ці побачили, як класно, давайте фінансувати. На останній зустрічі, значить, з департаментом так само. Не напряму, але посміхаючись онлайн і так далі, я кажу, поясніть свою позицію, голова департаменту, як ви це бачите. Вона так само сказала, що щодо спроможності Гайсинська лікарня, вона відстає. Коли я говорю з директором Ладижинської лікарні, кажу, у нас же і то, і це, і ангіограф, і все. І, коротше, ми через рік і 2 заберемо кластерну лікарню у Гайсена, і вона там, як би там не було. Ну, я можу тільки це слухати, да, і, в принципі, констатувати, да, але вона каже, що реабілітаційне відділення на 20 ліжок в Гайсені буде, але ми плануємо, от ми мережу свою регіональну, у нас же децентралізація, що тоді 40 буде в Ладижині і 20 буде там. І, в принципі, з точки зору навантаження або потреб, ми будемо покривати ці потреби. В Ладижині зараз дійсно багато, бо санаторій був, там багато військових, там багато людей потребують, вони проходять, це просто рівень треба розширювати. Причому Гайсен ще навіть, здається, не був на цей рік законтрактований. Ну, 3 місяці тому, як кластерна лікарня. Ладижин вже був законтрактований на пакет.
А фахівці в них є?
Фахівці вони перейняли ті, що були в санаторії. Тому вони натягнули. Ну, давайте ми не будемо говорити, які фахівці там і так далі. Да? Але вони були по кількості, ну от як от ми бачили, да, наприклад. Тобто вони по кількості, по всьому вони достатні для того, щоб отримати цей пакет. Лікарня непогано, амбітний керівник, місцева влада підтримує, гроші є, вони розвиваються дійсно послуги. Тобто я нічого не можу сказати. Але це те, що у нас бракує, це регіональне мезорівень, управління на рівні регіону, де вони мають виступати не як оце іноді зараз приїжджають контролювати, давайте мені на стол і все інше. Да? Вони мають надавати аналітичну підтримку, тобто інформаційно-аналітичний центр регіону, департамент охорони здоров'я, як скерувати, змінювати, де концентрувати послуг. В принципі, в цьому страшного нічого немає. Відстані там 30-40 кілометрів, Якщо вони так вирішили, нехай так і буде. 20 ліжок там, 40 там, і нехай воно працює. Але от тоді комунікації ось ці, ми розвиваємо тільки кластерні лікарні. Вибачте, я вже скажу, оскільки ми в МОЗ знаходимося. Я вже не один раз звертався. Нам треба навчання проводити, для закладу охорони здоров'я. У нас є заплановані навчання в рамках центрів досконалості. І тут теж має бути навчання. І коли я запитую, а де в планах можна відставити Ладижинську лікарню, а вона загальна, нельзя вставити. А ліжка там будуть. А хто це буде тоді оплатити? Ну, там французька сторона може. Тому, коли я піднімав це питання, можливо, вже наступний рік буде навчання, але навчання буде не як загальної лікарні рівня громади, а має бути навчання як кластерної лікарні, яка надає високий рівень стаціонарної допомоги. Треба її включити туди, але додати ті компоненти про чергові, управління фінансами і так далі, вдосконалювати це. Так, я вам описав ситуацію?
Да, дякую.
Це вже питання до французької сторони, яким чином вони приймали стратегічне рішення, куди вкладатися.
Коли дивишся на дашборд і на проти
Ні, дивіться, гарний проєкт, видавши небагато грошей. За нього заплатила місцева влада. У нас децентралізація. Вони приїхали на виставку Rehabilitation України. Їх побачили Францію. Ну, все, гарний проєкт, потреба є. Є потреба, є в її не вистачає, не вистачає. Ну, це поїхало далі. А далі тепер треба узгодити. Значить, так, якщо департамент класу, то хорошо, ми там залишаємо 20 і не розвиваємо більше.
Як не вистачає, якщо кількість ліжок, які планувало міністерство, і перевищили саме стаціонарною. Отут теж це потреба стаціонару і амбулаторії. Хто буде лежати на стаціонарі?
Вибачте, це ми трохи це ми в іншу дискусію переходимо. Це погодиться з амбулаторною допомогою. Зараз всі побігли створювати стаціонари реабілітації, там, де можна і не можна.
Саме лежимо в стаціонарі.
Це окрема історія, тому що комунікація, вибачте, я зараз скажу. Це як ми розвивали програму медичні гарантії і говорили в місцевій владі, купуйте обладнання, вам буде більше пакетів. Ми зараз йдемо приблизно по тому ж самому сценарію. Купуйте обладнання, відкривайте, бо вони вигідні. Вони вигідні, ці пакети, по ним багато грошей. І коли я, вибачте, на зустрічі приходжу на форумі, типають і всі кажуть, керівники центрів досконалості дуже класно фінансуються. Керівники закладу кажуть, так ми ж з них ще гроші зберемо на те, щоб підтримувати інші напрямки. І всі починають слухати, виходить орган місцевого самоврядування, а що б мені не зробити? І підходить мені телефонує керівник загальної лікарні. Каже, ми не хотіли навіть загальними ставати, а тепер від нас вимагають амбулаторну реабілітацію. У нас, каже, немає людей, каже, у нас вже хірургії давно немає. І ми не хотіли бути, вони ж, у нас як поліклініка була, а тепер мене ж нагинають, департамент каже, давай створюй, де я людей візьму, де я взагалі це зроблю?
Ну, я бачу, ми зайшли в
Дякую вам.
Але вона може бути вічна. Дякую. Апдейти, якщо ще когось є, або ми переходимо до наступної частини. Супер.
Більшість україномовні, так? Так. Добре, тоді перед іноземними колегами перепрошую, я все-таки українською продовжую. Степан з Солитери. У нас буквально декілька апдейтів. Ми закінчили з впровадженням оцінки потреб в 8 закладах, в 7 прифронтових регіонах. Це Одеса, Миколаїв, Запоріжжя, Дніпро – 2 заклади, Харків, Чернігів і Суми. На сьогодні, що у нас п'ятниця, сьогоднішнім днем у нас ці команди вже пройшли обидві. Ми розподілили таким чином. 4 команди їдуть до Києва, Охмадит, як центр досконалості, проходять там теоретичне практичне навчання. І 4 команди їдуть до Львова, лікарні Святого Миколая. Там у них точно таке саме навчання за тією самою програмою. Теоретичну частину у нас в цьому підтримує центр досконалості великий в Італії. Він нам допомагав з розробкою матеріалів на фоні тих потреб теоретичних, які ми зібрали з лікарень. А практичну базу вже безпосередньо центри дають самостійно. У нас є певний план, і ми за ним йдемо. І сьогодні вже всі 8 лікарень закінчили перший модуль. В наступному місяці, на початку наступного місяця, ці ж самі команди будуть починати наступний навчальний модуль. В принципі, з основних моментів це все. Якщо в когось є якісь ще питання, якщо зможу, відповім. Yes.
Translation is coming.
Yeah, just to add that, so all of this is pediatric. I don't know if I didn't say that. So all the 8 hospitals that we're engaging with are all Children or Blast Hospital or city hospitals, but all dedicated to pediatrics. So the need assessment identified both the needs and the needs of the hospitals, and also we did the discussion with the Center of Excellencies, asking them, okay, what are the conditions that you find that could be treated closer to home rather than coming all the way to the Center of Excellency to be treated there. So there has been this exchange between the Center of Excellencies and the 8 hospitals in the front line. So yeah, and then we communicate with the Center of Excellency in Italy, and they support in the creation of the modules. So the first module is finished, and it was mainly on TBI, pediatric TBI. The second one will be on cerebral palsy, and the third one is still under.
Порушення постави. Postural disorders.
Yeah, postural disorders. And so these are for now the modules that have been identified from the need assessment and the requests. And I wanted to say something else. And the training is mixed between theoretical parts, practical parts, case studies. And then I think the materials, when it's finished, it will be available if you want to replicate it. Yeah.
Thank you. Thank you so much.
It is translated in Ukrainian. Yeah, everything's translated.
Can I ask you the topics that you choose? It was from the hospitals? They fill the questionnaires? It was the request from them?
So the need assessment was very intense, and we will have the report soon. So maybe in the next meetings, we can also share the results. So the need assessment was a combination of questionnaire, observations, and questionnaire on what do you feel stronger, but also questionnaire on what type of conditions you see more frequently. Okay, so it was a triangulation of what condition do you see more frequently, and so you would need more, I mean, the training would have more impact. What condition you feel like you want to have more information, and then also the observation from the rehab experts on what were the techniques that were maybe not up to standards. And all of that was also discussed with Ahmadit and with Sir Nicholas to say, okay, basically what we wanted to make sure is that the mildest condition that could be treated in non-Center of Excellencies hospitals are treated there, and then that they know how to recognize when actually it's a more intense and, not acute, but more complicated condition that might require moving into a Center of Excellency.
Thank you.
Thank you, colleagues. Do we have more updates? Sure.
Всім доброго дня, Наталя з організації МОХАД. Я, на жаль, сьогодні змушена повідомити, що організація МОХАД призупиняє свою діяльність в Україні у зв'язку з припиненням фінансування від наших донорів. Останній день нашої роботи буде 18 липня. Ми маємо ще декілька тижнів, щоб завершити, передати наших пацієнтів. Партнерам хотіла б подякувати за гарну співпрацю та, звичайно, просто технічну роботу.
Дуже вам дякую. Шкода нам таке чути. Але якщо у вас є пацієнти, або ви вже робили оцінювання громад там, де працювали, і там ще немає покриття партнерами, а партнери планують розширення, це буде супер, якщо ми зможемо ідентифікувати, де вже є оцінювання ваше, і щоб інші партнери.
Так, насправді було чудово, тому що на даний момент ми працюємо в 3 лікарнях, і поки ми працювали, в 2 лікарнях розширилися їхні команди реабілітації, ми поступово зменшували їхні команди, оскільки збільшувалися їхні, і більше зосереджувалися на навчанні місцевих команд. В одній з лікарень такий був запит нашого донора, коли ми починали працювати, реабілітації взагалі не було, і задача була скажімо так, надихнути керівника лікарні, власне, на створення свого реабілітаційного відділення і показати йому, якою має бути реабілітація, як це може працювати. Він поступово почав це робити, але на даний момент зміг найняти лише 3 фахівця, яких, звичайно, недостатньо для того, щоб це все покривати. Тому в цій лікарні насправді найбільша потреба, тому що якщо в інших 2 нам є кому передати цих пацієнтів, то в 3-й просто немає.
А скажіть, будь ласка, це кластерна, мідкластерна, загальна?
Загальна.
Ага. Добре. Звичайно, я думаю, я допишу в імейлі, коли буду робити circulation ваш імейл, щоб партнери могли з вами зв'язатись, і якщо буде можливість, перекрити.
Дякую велике, це було б чудово.
Так, дякую. Colleagues online, do we have some updates from your side to provide, or we will be moving further? You can always raise a hand, and we will see your interest in speaking up. Okay. So,
Я можу повідомити, що Віталій Пчолкін, група активної реабілітації. В принципі, за травень місяць відбулося дуже багато різних подій, починаючи з того, що ми відновили програму таборів активної реабілітації для людей з травмою в шийному відділі. Останній раз ми робили це у 2018 році. І, в принципі, доволі цікава досвід, новий певною мірою, бо були військові з такими дуже нетиповими комплексними порушеннями, там, зокрема, пораненнями рук, окрім всього іншого, що нам зрозуміло, тому мали хороший досвід. Плануємо наступний табір звичайний в Рівненській області в серпні місяці. І також відбулося декілька міжнародних подій, участь учасників від України в першому таборі міжнародному таборі активної реабілітації, який відбувся в Греції. Організаторами виступили організація з Норвегії Сунас Тілсен.
Rehabilitation
Ну там Сунас, це теж благодійна організація, у них при центрі. І зараз теж команда від України поїде в якості інструкторів на табір в Швеції. Тобто ми набуваємо такого досвіду цікавого міжнародного. В частині навколо реабілітаційній, можливо, є сенс відзначити, що ми таки завершуємо реалізацію практичного проєкту по облаштуванню житла. Тобто, якщо до цього ми консультували 2 роки безпосередньо, як сприяти безбар'єрності, то зараз ми маємо 5 таких класних кейсів, де ми безпосередньо впровадили ці зміни, над якими ми працювали рекомендаціями. Це 5 військових, 3 у Львові, 2 в Києві. І досвід цікавий, його точно треба розвивати, бо дуже хороші відгуки, я сподіваюся, вдасться їх показати дуже добре. І стосовно програми «Перший контакт», також завершили стажування додатково 3 інструкторів в Харкові, в Дніпрі і в Одесі. В Харкові дуже цікавий випадок, бо інструкторка, наша майбутня інструкторка, я дуже сподіваюся, вона є психологом в лікарні, працює, має ураження спинного мозку, і по факту це такий, може, перший приклад буде прям роботи в складі команди цієї людини, але будемо дивитися, що вона нам дасть. І зараз вимушено на місяць припинили, офіційно припинили програму «Перший контакт» в лікарнях, тобто зараз через відсутність фінансування цей період. І залишаємося на таких волонтерських засадах, поки продовжують ходити. А в ТМО ми ті 4 інструктори, які були за підтримки моментом, працювали вже з січня місяця, ми на таких теж витягуємо як можемо, теж не дуже добре. Певно, це основне. Так, дякую. Та й очікуємо на підтримку ВООЗ та і зустріч готуємо. Дякую.
Може, хтось з колег онлайн має натхнення? Окей, якщо будуть якісь коментарі, ваша рука, завжди її побачимо. And we are moving to the next part. I think Marty will take lead and will introduce what we wanted to make in this exercise, but it's discussion of current gaps. No?
It's Friday after, my goodness. Yeah, no, thanks, Sinya, and thanks everyone for your updates. There's so much rich information, and thank you to AI note-taking. We're going to be able to capture it all and share it with you. I mean, this final topic really is just to hear from you, and I think most of you have covered where you're experiencing gaps, particularly in funding, where you've had to stop programming because of, most commonly for most partners, it's related to the US freeze. But I think, you know, from our side, we really want to document this very clearly and be able to raise these issues with the donor community as well. And of course, the broader UN community. So if you want to provide more detail, please do reach out via email. Otherwise, we have it documented from the updates today. And I just wanted to just, I suppose, do a bit of a quality check with this group on the priorities that we discussed first thing in the morning, and to hear from you if you feel that there is a critical element of rehab system development that we're missing right now. I'm hearing some colleagues talking about rehab nursing, for example. And although, you know, we try and capture this within the looking at and considering the rehabilitation workforce, we know that rehab nursing, particularly critical in many acute injuries, and impacts the entire trajectory of care and rehabilitation outcomes, but also, relevant for all patients who are receiving rehab for non-traumatic injuries. So I'm hearing that this is something that colleagues are wanting to focus on, and I know that colleagues from SUNAS in Norway had done quite a lot of preliminary work on rehab nursing. So for those who are interested in that, I encourage you to connect. I see Andrew Scanlon online here. And I think Kirsten as well. So just connecting the dots around that, because there are organizations who have already started even last year to push the needle here. And certainly at WHO, although our team are really focused on the traditional MDRT per se and what's possible for the NHSU MOH in the short term, I think that this is really important to note, and also continue to feed back into the collective in terms of what you learn, what your experiences are, etc., for different conditions in different settings, etc. So I just want to open the floor one last time today, and hear from you if you think that there is any critical priorities or critical gaps in coverage, whether it be from the National Health Service. I think these are clear, but could there be more that the cluster, that we as a rehab working group, that NGOs or UN agencies, non-state actors could be addressing, that we should be raising up to a higher level? So it's an open question.
I have one small question. I forgot to ask when you present the general rehab forum findings and the general partners, that in one slide it was mentioned JICA. It was Centers of Excellence slide, and the mention about the equipment procurement. Which type of equipment? Do you have any idea which type of equipment they will procure? Will it be urodynamic, maybe, equipment?
There has been some discussion from them around urodynamic equipment, but it hasn't been confirmed yet. So JICA are supporting in taking SCI rehab teams, usually 5 at a time, over to Japan. They spend a month there working and training, bedside training, and then they return. So I believe the Cleven team, SCI team, are there now. And they are looking at what kind of equipment needs to be procured for the facilities, and also
we discussed the possibility of urodynamics, but of course with the caveat that no facility should receive urodynamic equipment without the training to go with it. And so it's sort of an ongoing discussion in how we or another partner could support that other component of the procurement and provision.
For us, it's as well, like not for us, I think for all the partners, that's a still open question because, for example, our colleagues from Norway quite open to do the training, having good training resources, but the biggest issue it's equipment. And to understand why I was asking about equipment, that's already fully finalized. To understand which type of equipment, because for sure we do not need such equipment for all the centers. We need them for centers of excellence who are dealing with the SCI. And to understand and to be on the same page, it's tremendously important because it will depend one from another. We share in past with Ministry of Health the list of equipment, a general list of equipment we were planning to procure to TMU, but unfortunately due to the suspension and then termination of SRSHS project, we were not able to finalize the task. So that's quite open discussion with SUNAS. They are open, they're having resource, human resource and other, but like equipment still the case.
What I can suggest is connecting with Maria Krivakov, who is in charge and leading and is much more into the detail. And also Maria Lipolchenko. So I can connect you unless you have their email. So they sort of have the oversight of the detail there. But yeah, I think it could be really useful to make sure that.
Yeah, because the basic equipment, we know that Vinnytsia already received from WHO equipment and Rivne already received. So to understand like the general scope.
Exactly. Yeah, absolutely.
Ask a question. Kind of, you mentioned that kind of WHO is having piloting the community-based rehabilitation in Vinnytsia. Yeah, can you kind of share just a bit kind of what is the nature of the?
Sure. So the plan is, and we begin with just on Tuesday we will gather the local authorities, head of health, etc. To provide a dedicated awareness raising session and engage around the need for community delivered rehabilitation, what it means and what the utility of it is at this particular moment in time for Ukraine as well.
Or for Vinnytsia Oblast administration,
in
Vinnytsia.
And also engaging primary healthcare physicians as well, and heads of general hospitals. So that will be sort of more of a broad stroking presentation and engagement where we can discuss, ask questions, etc., and really try and shift maybe some attitudes or inform of the utility. And once we have finished that, and on Tuesday we will make a decision on which hospitals to focus on. So we will likely target general hospitals with functioning outpatient departments. And the reason for this is we conducted an assessment in Vinnytsia in early May, and we looked at oblast, rayon, Gramada level from a perspective of health, but also social care. Looking at could we inject rehabilitation services, even if it's a task shifting approach with supervision of a rehab professional into the PHC level, particularly in some Gramada level facilities that are so well integrated, particularly with inclusive resource centers, etc. It was a little bit ambitious, and I think we could get there in the next couple of years, but for the moment, we will stick with general hospitals that have essentially mobile outreach teams. And so therefore they will be funded by the outpatient package of the NHSU. So we will train just 20 sort of master trainers and those who can lead the process in what's called the WHO basic package of rehabilitation interventions. This is a new package that was developed by our HQ and hasn't been released yet, so we're waiting. They're a bit late. But I'm looking forward to sharing it with everyone once they finally do that. But essentially the basic package for rehab interventions, it has 8 modules. To train up in the full 8 modules, it would be a continuous 2-week course. So this year we're just focusing on, we're going to provide 1 week of training, and we will focus on mobility, self-care and communication modules, and that will be 1 week. It's going to be dependent on the facility and the HR in each facility, etc., and what the services are like outside of the hospital in terms of, you know, each team's setup. But the idea of the basic package is that it enables task shifting among health workers. So it doesn't enable you to task shift to a social worker, for example, but it does allow nurses to be more involved, family physicians to be more involved. It depends on the country. In Ukraine, we're definitely not targeting family physicians, but with this training for them to implement, but we certainly want them to be involved in terms of, you know, looking further towards a case management role or adding this into their repertoire of their existing sort of case management role, similar to how they're managing MHPSS, etc. So we're not planning to overload them. So it will still sit at the hospital level. And really this year, the aim is to try and test out how this can be shared, what could be the distribution and roles and responsibilities in this particular space, very similar to what we're doing in acute, knowing that the workforce shortage is not going to be solved anytime soon. And then we will conduct a lessons learned and look at scaling up or, of course, course correcting, etc. So once we have the basic training in place and the basics of the project set up, we will bring on an implementing partner to implement the full project and conduct the analysis, etc. So it's not direct implementation on our side once the components are set up. So we'll be doing a call for proposals pretty soon. So it's in its infancy, but we hope to have something interesting for you by next month to share.
Which professions from these general hospitals you're?
It depends on who's there and what we can kind of negotiate and who is available and how the willingness, I suppose, of the authorities. But ideally, it would be at least a physio, maybe working with an assistant, physio or ergo assistant. That would be the ideal. But the possibilities are going to be very sort of specific, but that would be kind of the idea.
And which package from NHS they will?
The outpatient package.
Outpatient?
Mm-hmm. Mm-hmm. That was the request of MOH that we anchor it there, so we can then reflect back and look at costing and that kind of thing, and it's covered already, and then it's easily more scalable in other oblasts if there's already a mechanism rather than because we're not going to get in before the next PMG round. So then, you know, at least we can set something up that can be funded next year without major changes to the PMG. Obviously, that's also a goal, but yeah, we're kind of working along 2 streams.
So in theory, the models you're proposing is kind of task shifting within existing rehabilitation team of the hospital with potential of having like mobile teams going to primary healthcare localities. Is this the
possibly or more likely going to the patient's home?
Oh, okay.
Yeah. But all PHCs have transport, so we're looking at making the connections to practically bring it to life. So in some gramadas in Vinnytsia, the PHC and social workers were already working really closely. The nurses were really involved, and the model was quite integrated, even though the funding sources and the services were, you know, in principle but they were really working together. And so we're trying to connect into some of those good practices and see how we can build the pathway up.
You remember I was asking you before about this kind of sharing the kind of experience of other European and not European countries in community-based rehabilitation services, because your colleagues kind of provided just Chile, but kind of even looking and quickly scanning the kind of evidence. There is the evidence in Sweden, in Norway, in Australia, in Canada, where kind of different models kind of are described, all have pluses and minuses. Can you go in just to have such a study? Or kind of you decided to skip this this step because in order just to say something to the local authorities, they have to understand what models are available. So kind of we are not reinventing the wheel. I understand we have our own setup of healthcare facilities at the primary healthcare level, our social services, this territorial services, kind of services for people work. But are you thinking of this study or you?
Yeah, I mean, it's on the horizon. I think for us, we're always trying to work along two tracks. The request from MOH was pilot as soon as possible and reach people, right? So it's not the ideal process, but also we need to reach people as quickly as possible. So it's learning about, I think, for a lot of organizations, us included, particularly with the decentralized system, that one gromada to the next, one oblast to the next is very, very different. And so we recognize also that although it's really valuable and it is to look at models from other countries, and we have done that internally, but not necessarily written a report or a formal study, you know, I think we need to really be learning about what's happening in reality at the community level to inform the model. And so we need to also connect in realistically to what's available. But this is very much informed, I would say, mostly by the UK. Because in the UK we have rehabilitation in healthcare available at every level of the healthcare system. And they also have jointly funded packages of rehabilitation and social care where it's a multidisciplinary team and the funding's coming from different places, and it has and is often linked into a polyclinic. So this is the sort of the thinking, but...
And I understand the logic because kind of our kind of financing is copied from NHS in UK.
Yeah.
So that's why I understand the logic.
Exactly,
but it's still kind of... It's still useful to give people some kind of rapid and dirty kind of sketch of what is possible. And there's already kind of learning lessons from the system who's been doing it for more than 10 years, or sometimes kind of say to learn from them. Okay.
Yeah. Okay. Thanks. Yeah, we can definitely look at that. I think it's simultaneous of doing and learning as we sort of.
But you said you already have some internal kind of analysis, like rapid analysis of the model.
Yeah, that's right. And certainly in cooperation with our regional colleagues, not just at Euro, but in other regions as well, sort of knocking our heads together and looking at it. But I think in reality, from within Europe and then also looking globally, region to region, no one country and the next are the same. So it's very different to inpatient rehab, where it's almost identical in many, many countries, particularly Europe. Community rehab is a completely different kettle of fish. And so, and I think that's what, if you were in the session with Anthony Dutine, who's our global head of rehab, he sort of said, there's no one size fits all when it comes to the community, because the way that, you know, health and social care is funded, HR, etc., it's just so much more unique the further away you get from a tertiary or a secondary hospital. So what we're sort of doing is, of course, NHS and looking at being informed by the STARS assessment and what we know about the workforce and the work that partners are doing, like Yevgeny at the gromada level. And trying to bring the best practice into that, knowing that there's no perfect standard. It's really looking at how, with what the resources that you have, can you meet the patient's needs from a health perspective. But yeah, point taken, push for it.
I think if I'm kind of a person kind of trying to understand what I can do in my community, I would love to have some, not ideal, but still working models And especially because we are so much, we are close to the system that Lithuania had, or Estonia, and or some, even Australia,
yeah. No, we hope by the end of the year to at least have a draft model to suggest and scale up with, and then continue to reflect. So
because one thing we didn't want us to do within our program is we have this task of helping to develop community-based rehabilitation and do the patient pathway. Is just instead of looking around, but have some models which are already ready just to be scaled up or tried and and implemented, because we had 4 years now, 3 years and a half implementation. So it would be interesting really to agree and pick up, for example, a couple of models who have a lot of potential to be acceptable and culturally acceptable for right?
We'll certainly share the finalized model that we'll test in Vinnytsia in the next couple of months. And so the discussions around that in detail will take place on Tuesday. And then we'll probably move quite quickly. So of course they're anchored in international best practice, but also what, as you said, is achievable and culturally acceptable and all of those other things. So we're happy to share that with you as soon as ready. Yeah, of course. Andre, online.
Hello.
Hello.
Yeah, do you hear me well? Yes. Okay. Thank you for this meeting. I mean, it was really interesting. It is really interesting, and I didn't introduce myself at the start, and I am physiotherapist, and I am PhD student in management, on management in healthcare. So that statistics from 1 second, sorry. So that statistic from Ksenia and other people, it was really interesting, and I wanted to share, or I want to share about my small research. I think somebody already saw that. So it was interesting for me to find that something around 30% of students who was graduated from university recent time, I mean from 2016. So only 25% work, officially work like physiotherapist or ergotherapist, I mean in our health system officially. So question is regarding to that models, projects about community delivered rehabilitation. Are you consider approach for specialists to work as individual entrepreneurs?
Individual
entrepreneurs.
Private.
Yeah,
entrepreneur.
working in the field.
Oh. Yeah, I mean, thank you, Andrew, for the question. For sure, the private health sector, particularly at the community level, is critical. For us, however, of course, the goal is to use and engage the resources that are available in the community and deliver a public health intervention. But I think in terms of engaging private sector or having health administrations being able to attract young, skilled, or old and skilled, whatever, experienced clinicians, particularly at the community level, is quite challenging because salaries are not as attractive. And I think with the rehab workforce, especially with the younger guys, they don't want to be in the community because it's not very sexy, honestly. I was the same when I was an OT, and I always wanted to be in the big trauma hospitals. So there's a lot of challenges, I think. And I think it's also a challenge in terms of setting up a relatively basic service when there are other private services available, but also these private services are not universally accessible. So it is a slower process.
Let me add something. Okay. Of course, for my side, it is not about, mostly not about private sector. You know, it is about gap in statistics. I mean that from that students who was graduated from universities, around 70% of them work somewhere, and we can see them not because they not work as a physiotherapist, of course, just because in our legislation, of course, it's not directly to you, but you can help us with this. So regarding our legislation, physiotherapists don't have possibility to register himself as a practitioner. So it's really about gap in the system because generally we talking about working in team.